Recording in progress.
Good morning, good afternoon, good night, depend of the part of the world. Now is the day of the second summit, World Summit about research. We start in the second part of our day, and I'd like to share the program that you have today. You start with the keynote conference about whole system research methods in healthcare with Nadine. Then you have a panel about advances in research in TCIM in Central and South America and South America. Then you have active pause with some activities, integrative activities and relaxation. Then you have our last panel about TCIM collaborative work, networks and consortiums. And we'll conclude with our last conference about the world perspective of investigation, research that we bring. Then we'll start. I will pass the talk to the moderator, Rafael Dal Alba. Não consigo. Wait a minute. Rafael Dal Alba, it's national consultor of chronic disease of TCIM in the Pan American Health Organization, Brazil. Please, Rafael, you can present the next speaker.
Thank you, Ricardo. Hello, everyone. I'm going to introduce Dr. Nadine Yas. Dr. Nadine Yas is an assistant professor in the Department of Law and Legal Studies of Carleton University in Ottawa, Canada. Her program of research focuses on the regulation of governance of medical pluralism with an emphasis of preservation of traditional indigenous medical knowledge within a post-colonial context of biomedical dominance worldwide. Her work furthermore interrogates ways in which conventional clinical research methodologies may appropriately represent the complex multinodal healthcare approaches, characteristics of traditional and complementary medicine system. Okay, Dr. Nadine,
Hello, thank you so much to the conference organizers for this invitation to speak with you today about whole systems research methods in healthcare. My name is Dr. Nadine Ijaz, and I am an assistant professor in the Department of Law and Legal Studies at Carleton University, which is in Canada's capital city of Ottawa. Now, although we are going to be talking today about clinical research methods in some detail, I want to let you know upfront that I am not a clinical researcher. So instead, I am a policy researcher and a medical sociologist. My area of focus is in traditional, complementary, and integrative medicine. And prior to my work in the academy, I spent many years working as a medical herbalist and also a shiatsu therapist. So then why is it that I would come and be a person to talk to you about clinical research methods? This is because clinical research methods have a lot to bear upon policy and the way that medical decisions are made in the healthcare sphere. And there are many assumptions that underlie those decisions. And so I want us to take a look at some of those assumptions today and what it means to do research in the area of traditional, complementary, and integrative medicine, where some of the underlying assumptions that drive healthcare may be quite different from what's driving conventional biomedical healthcare. Now, you may be familiar with the hierarchy of research methods represented on the slide here, which is a foundational conceptual model in evidence-based medicine. We see here that some research methods, in particular the systematic review, and just below it, the double-blind, placebo-controlled, randomized control trial, are considered the best or highest forms of evidence within this system. The idea, of course, is that these methods would be considered to produce the most reliable, rigorous, reproducible kinds of data with the least bias. So when decision makers or policymakers are looking to the scientific literature to make decisions about care, so the story goes, they look first and foremost to the forms of evidence represented at the top of the hierarchy, unless those forms of evidence are not available for a particular type of intervention. Then they would look for the quote unquote best type of evidence, whether that involves non randomized trials or observational studies and so on down the hierarchy. Now, before we start to talk in detail about clinical research methods, and specifically those which come from the evidence-based medicine model, I will put my medical sociologist hat on and remind everyone that evidence-based medicine is really just one way of doing things that people have invented. Historically, it comes out of the biomedical, or what some people call allopathic or modern conventional orthodox Western medicine, which is, of course, in the scheme of human history, a fairly young system, which borrows in many ways from traditional and indigenous systems of medicine. Philosophically, biomedicine or conventional medicine comes out of the European and scientific revolutions out of the 17th century. It is a system that carries many assumptions within it, for example, the idea of mechanism, or that the body, the human living organism, is fundamentally something that works like a machine. We see this reflected in ideas like mechanism of action, which is something that often comes up in clinical research circles, wherein biomedical scientists want to find out exactly what biochemical or physiological pathways are impacted by a particular therapy. It's actually considered a very high form of knowing in biomedicine when we understand not just if something works, but how it works mechanically. Fine. Now, of course, biomedicine is a system with many advantages. Politically speaking, however, it is a dominant form of medicine that is sanctioned by many governments across many countries, which is why we often just call it medicine. There's also considerable capital, money, and other resources available to underwrite and further advance this system, so much so that we often think of biomedicine as something neutral or something universal, something apolitical. In fact, historically, biomedicine is quite tightly interwoven with capitalism and also with colonialism, and has been used, especially in the global south, as a tool of empire, as a tool to suppress, marginalize, and in some cases destroy indigenous healing traditions. So yes, conventional biomedicine certainly is a system that helps many people. It has many advantages as an approach, and it is a valuable form of state-funded healthcare in many places. But because we're going to be talking about biomedical research methods, we need to say that it is certainly not the only legitimate way of practicing medicine or healing, and the scientific modes associated with biomedicine, that is, its ways of thinking and researching and analyzing and documenting, are not neutral or absolute. They're not universal. They're not inherently superior to other ways of knowing or doing. Now that was quite a preamble to get us to the focus of today's talk, which is what does it mean to use conventional biomedical research methods, the approaches lifted up in the evidence-based medicine model, to study therapeutic approaches that do not generally fall within the boundaries of dominant conventional medicine. Now these approaches, which we often group under the concept of TCIM, or Traditional, Complementary, and Integrative Medicine, include practices deriving from indigenous medical traditions such as Chinese and Ayurvedic medicine, and also a very wide range of local indigenous traditions the world over. TCIM also includes more contemporary practices that we sometimes term complementary, or from a sociological perspective, heterodox, because they're not part of orthodox medicine. And these heterodox approaches range from chiropractic and massage to homeopathy, anthroposophy, naturopathy, and others. Now, before we move on, I want to say two very important things about indigenous medical traditions. First, in the evidence-based medicine world, we may hear messages about how particular therapeutic approaches need to be researched in order to be quote unquote validated. And I will say explicitly that yes, there will be many advantages to undertaking clinical research, which we'll talk about soon. But let me also say that indigenous healing practices and ways of knowing have inherent value. They are irreplaceable and profoundly important culturally, and that is something that fundamentally requires no confirmation from cultural outsiders. End of story. So when we talk about validation in the research context, let's be very clear that we are talking about biomedical integration. That is, the project of evaluating unorthodox therapeutic practices or marginalized therapeutic practices for inclusion within our politically dominant systems of biomedicine. So again, it's the pursuit of integration that often drives the research impulse, not a need to determine whether long-standing, culturally important practices have value, which they clearly do. The final thing I will say on this front is that traditional and indigenous therapeutic approaches, which are so often at the heart of so-called complementary and integrative health, whether we're talking about yoga, acupuncture, mindfulness, or herbal medicine, are not static, ancient ways of knowing and doing that don't change, but rather contemporary, evolving systems of practices which may take up biomedical concepts or co-evolve or hybridize with a range of therapeutic approaches. All right, let's talk about research. Now, as we turn our attention to the practice of whole systems research, let me introduce a concept that will be driving our methodological conversation today. This concept is model validity. Now, model validity is really a fairly straightforward idea in which we want to use an appropriate tool for a particular job. We want something that fits. The job here would be evaluating the effectiveness of a particular therapeutic practice, typically a TCIM practice of some kind. To be more specific, what we were looking for is a good fit between the research design that we're using, the intervention that we're studying, and the underlying therapeutic paradigm. Let's take traditional acupuncture as an example of why model validity is so important and how questions of research design can very quickly become complex when we're talking about TCIM therapies. So if we're talking about traditional acupuncture, meaning acupuncture practiced from within the conceptual framework that derives from traditional East Asian medicine, so Chinese or other forms of East Asian medicine, we're talking usually about the insertion of needles into multiple sites across the body, acupuncture, we should really think of it as a multimodal therapy, a complex therapy, not only because there are multiple needles being inserted, so if you will, the treatment itself of acupuncture is complex in and of itself, and it is made more complex by the fact that often it may be combined with other therapies such as moxibustion, sort of the burning of the mugwort herb around the needling sites, and or cupping in those areas as well. So that is definitely something to note, that acupuncture can be seen as a multimodal treatment. Now, if we're talking about point selection, right, how we decide where to, or how a traditional East Asian medical practitioner might select their points, we have to consider that this would not necessarily be from a biomedical perspective, right? So a patient may come in with a particular biomedical diagnosis, but the practitioner will do their own diagnostic process informed by Chinese medical principles or East Asian medical principles such as qi and blood, yin and yang, various forms of stagnation that might be evident across the body, excesses and deficiencies, and different body systems that might be affected. And the point selection will be determined on the basis of that particular diagnostic assessment. And often with acupuncture, we should remember that in a traditional context, the treatment will not necessarily be the same every time the patient comes. The treatment changes with the patient. As the patient's symptoms change, the practitioner will also use different points. So all of these things make acupuncture a rather complex type of therapy, and the big question is, if we're wanting to sort of within an evidence-based medicine framework study this type of therapy, and people have been doing it. There are actually about 13,000 acupuncture studies over the last 25 years, so it has been done quite a lot. But the big question is there a good fit in many of these studies between the research design, the studied intervention, and the underlying paradigm, which is the East Asian medical paradigm? So let's consider that we are trying to develop a study research design for studying a particular traditional acupuncture intervention for, let's say, a particular condition. If we're wanting to engage in sort of a best practice from a biomedical evidence-based medicine perspective, we might consider whether we could undertake a placebo-controlled randomized control trial, which of course is considered the gold standard, the design that's at the top of the methodological hierarchy. Now, right away, this design raises questions, which are not exclusive to acupuncture. There are questions that get raised for many therapies, even some biomedical therapies, and we'll talk about that. So, the first one is how to define an appropriate placebo for acupuncture, because as you know, it's fairly likely that the patient would know if they're getting acupuncture or not. And there have been, in fact, many attempts to develop acupuncture placebos. As it turns out, many, if not all of them, are biologically active placebos, so they are not inert as a placebo is ideally meant to be. This in itself raises problematic questions. And again, these are questions that have been raised in some biomedical fields, for example, among chiropractors, among psychiatrists, right? How do you develop a placebo for psychotherapy, for example? So these are not questions that are exclusive to the TCIM world, but they are certainly questions that we need to consider. The second question has to do with how can a study design, like a randomized control trial, contend with the fact that acupuncture might be a multimodal treatment, because essentially these RCT designs are designed to study a very specific intervention that is meant to have a very specific impact on particular biochemical or physiological pathways in the body, whereas a multimodal treatment is often more complex and may have sort of many effects, right? And so there's already some questions around what is it that you're trying to measure, right? How are you defining your outcomes? Now, in terms of outcomes, often in the biomedical world, we're talking about biomarkers, So biological markers, that a blood test or something of this type. With acupuncture, traditional acupuncture context, often the symptoms are described subjectively by the patient. They are evaluated also subjectively by the practitioner who may be doing pulse assessment, tongue assessment, talking with the patient, gathering symptoms. And again, the types of outcome measures that might be sort of considered optimal within a classical randomized control trial design don't seem to make a whole lot of sense necessarily if we're trying to study traditional acupuncture. So acupuncture was really the example, but this is not just about acupuncture. This is much bigger and really pertains quite broadly to a wide range of TCIM interventions, which fundamentally have some very specific characteristics that are often different from the isolated pharmacological compounds that the randomized control trial classically was designed to be evaluating. I'll just let you take a look here for a moment rather than go through all of these in detail. The big question becomes, if we are really wanting to evaluate using conventional clinical trial models the range of TCIM therapies that are being practiced with the aim of integration into conventional health systems, what do we do? How do we at the same time honor the rigorous scientific principles that are at the base of the evidence-based medicine model, and at the same time honor the practices that we're researching and the paradigms, the concepts, the diagnostic frameworks, which are quite distinct from biomedicine that are underlying many of these therapies. So for me, there are both pragmatic ways to move and also idealistic ways to think about this. So let's start briefly with some idealism. You can see here on the slide, on the far side, left side, we have the hierarchy, that the evidence-based medicine hierarchy that we've looked at earlier, and on the middle and on the right, we have some I think relatively idealistic models of revamping or taking a new look at how we conceptualize evidence, so that it is not just one type of hierarchy from the bottom to the top, but models where we say, okay, there are a range of different research models, and they can all have value according to context. And so rather than value, strictly speaking, one type of trial all over, like the randomized control trial, over many others, why don't we take this sort of broader perspective? Now, philosophically, this is good sense, I think, and politically, this is very difficult because of the how much credibility this hierarchy of evidentiary models, this evidence-based medicine hierarchy with the randomized control trial and the systematic review at the top, has really achieved worldwide. And so at the moment, it is really difficult to say, okay, let's flip this on its head and redesign it, although definitely those conversations should definitely continue. Now, to be a little more pragmatic, at least in the short term, we can talk about, are there ways of modifying or adapting the existing conventional research models, clinical trial models, so that they are more suitable for TCIM interventions? And this is really what we came to talk about today, which is whole systems research methods. Now, on the right hand on the slide here, you can see that myself and a few colleagues co-authored a review that was published in 2019 in the Journal of Alternative and Complementary Medicine. That was basically a scoping review of these types of methods. So let's look at that. The aim of our scoping review was to map out the range of TCIM clinical research designs that really centralized this idea of model validity, right? So that they were rigorous clinical trial methodologies, and at the same time we're honoring the way in which TCIM practices are practiced by practitioners on the ground, and honoring the concepts, the principles that drive those kinds of practices. Now, when we began this project, we were really looking for a wide range of clinical trials or clinical studies that were focused on TCIM interventions of broadly conceived, and these needed to be published in a peer-reviewed journal. Now, the inclusion criteria really that we defined indicated that any study that would be included in our scoping review needed to have to show the principle of model validity in at least two ways. And so these are the ways that we defined as specific characteristics that we wanted to see reflected in the research designs. Right, so often TCIM interventions are complex, as we talked about before. So we said, okay, we want to see studies that are addressing the fact that these are complex multimodal interventions. Another characteristic of a TCIM trial would be that it often care is individualized to the patient rather than sort of being predefined according to a universalized protocol. Right? We were looking for trials of therapies that had a salutogenic or a behavioral focus, so health promotion rather than necessarily only a disease treatment focus, or something that focused on the patient's behaviors, lifestyle choices, and so on. We were looking for trials that included patients who were also dealing with more than one health concern at a time, because that is often the kinds of patients that seek out TCIM therapies. And finally, we were looking for trials that address this principle that we'll call dual diagnosis. Now, when we're talking about dual diagnosis, we're talking about a study in which a patient may come in with a particular biomedical diagnosis, let's say diabetes, type 2 diabetes, or some other condition. Right. At the same time, they may be receiving a second diagnosis from within a totally different paradigm, for example, Chinese medicine or Ayurveda. Right? And that diagnosis would be quite different from the biomedical diagnosis, and it may be different from patient to patient, even if the patients are receiving the same biomedical diagnosis. So essentially, we were looking for clinical trials that documented these kinds of dual diagnoses as well. After screening many studies, we settled on 41 clinical trials that we felt were exemplars in the sense that they represented a wide range of both therapeutic disciplines, as you can see here on the screen, and also a wide range of clinical trial methodologies that reflected the whole systems context in which TCIM therapies are often delivered. Now, as you can see here on the slide, these are therapies from many different therapeutic approaches, but again, what they share is often the individualized, preventive, multimodal character of the treatment. Among the 41 studies were very small studies, including N-of-1 trials involving a single patient, all the way up to larger trials with about 3,000 patients. Some were very brief interventions lasting one day, whereas other trials were looking at interventions over a period of years. So again, there was quite a wide range represented deliberately in the studies that we chose. Again, with this idea of preserving a kind of diversity among the studies, the exemplars represented a wide range of clinical areas of focus, ranging from acute illness and chronic illness, various types, to mental health issues, reproductive issues. We had some studies that were not dealing with particular diseases at all, rather they were addressing patients with medically unexplained symptoms. We had some studies that were addressed to quality of life entirely. That was the whole purpose of the study. It was to measure quality of life impacts of a particular intervention. And similarly, we had studies that were addressing prevention of particular diseases rather than treatment, and rehabilitation after disease as well. Now, as you can see here on the slide, there were also a range of study designs represented. These are the most common ones that we gave a profile to. We have in the top in red controlled studies that are similar to probably the closest to randomized trials, randomized control trials. These were pragmatic comparative effectiveness trials, and I'm going to go into a fair bit of depth on those models fairly soon. We also had a number of pre-post observational studies in which one cohort, a group of patients are studied who received a particular intervention, but they're not compared to a control group, if you will. We had some N of 1 series trials and also some retrospective designs that were looking backward at the impact of therapies on a patient population. As I mentioned, I'm going to be focusing today on those pragmatic trials that I mentioned, and just want to make sure that everyone is comfortable with what I mean when I'm talking about pragmatic trials. So pragmatic clinical trials have come to be increasingly popular in the conventional biomedical world in the last decade in particular. And these are somewhat different from randomized controlled trials, although they do have features in common. So the classical randomized placebo-controlled trial is designed really to evaluate the efficacy. That means how the effects of a particular intervention under ideal conditions or idealized conditions where everything is sort of controlled in as much as possible. And you isolate out a particular intervention as much as you can, and you compare it to a placebo, which is viewed as neutral as possible. And ultimately, we're trying in those types of trials to establish the very specific isolated impacts of a particular intervention and ultimately linking that to a particular mechanism of action. And so in those classical designs, those randomized controlled, placebo-controlled trials, the aim ultimately is to also link to mechanism of action. Now with pragmatic trials, it's a little bit different. Pragmatic trial is less concerned with isolating all the external factors and more concerned with real-world effectiveness. Right? So these are often trials that study interventions as they're delivered in the real world by real practitioners without necessarily controlling for all the complex factors that a patient might be coming with and that also might sort of go on over the course of a trial. So the advantage of pragmatic trials is that they give us real world information about diverse groups of patients. Right. They also often in pragmatic trials, we have interventions compared not necessarily with a placebo, but with another intervention. So these are called comparative effectiveness trials. And as you'll see, as we'll talk about today, and also if you read the scoping review, many of these whole systems research studies that we identified are pragmatic comparative effectiveness studies that have something in common with a randomized controlled trial, but they're also a little bit different. So these pragmatic trials that we evaluated in the scoping review, a good portion of them were actually randomized controlled trials in the sense that patients were allocated to 2 or more different treatment groups in a randomized way. They were not necessarily all double-blind. In fact, a very small proportion of them, as you can see on the figure to the right, were double-blinded. Many of them were open-label in the sense that patients knew what it was that they were receiving, which intervention they were receiving. There was not an effort to blind to patients the treatment they were given, although often technicians who were recording the results of the intervention were themselves blinded to prevent bias on the researcher side. On the whole, the trials that we studied were not placebo-controlled trials. You can see again, there were a very small proportion of those we studied had a placebo control, although they did generally have a control. What kind of controls are we talking about? We are talking about active controls, so control groups where the patients who are not receiving the whole systems intervention, the TCIM intervention that's being studied, are receiving some other form of health care. That care was often usual conventional biomedical care, meaning that it was a trial in which the whole systems TCIM intervention was sort of going head to head, if you will, with conventional biomedical care to see whether the outcomes were similar or better or worse in either case. Sometimes the whole systems intervention was combined with usual care, and that was compared to usual biomedical care. And there were also a few factorial designs. For example, a factorial design example would be a study in which acupuncture would be compared as an active intervention with another active intervention that included the original whole systems intervention, such as acupuncture, with the addition of herbal medicine. So in many ways, these trials had a lot in common with conventional pragmatic trials, although there are some differences that we'll start to look at now. Another feature of many of these trials were that they included methods that are often not included in a conventional trial. And so those were including qualitative components and economic evaluations. So for example, some trials might include interviews with study respondents to learn more about the impacts of the intervention that wouldn't necessarily be captured in quantitative outcome measures. Others might include economic evaluations to compare not only the effectiveness of a particular intervention as it compared to usual care, but also the cost effectiveness of that intervention, which of course is important in a policy context if one is trying to sort of make arguments about what type of care is most efficient or economically efficient for a health system. Now here's where things start to get really interesting in the sense that we start to see how researchers were using these pragmatic clinical trial designs in ways that really adhered to the principle of model validity. Now you can see here on the slides that the particular interventions, the healthcare interventions that were being studied in the pragmatic trials that we evaluated, had a number of characteristics, of course, aligned with the whole systems principle that were often complex, multimodal treatment designs. The therapeutics were individualized to the patient, which is often not the case in a randomized control trial where the intervention is typically a standardized one. There were often behavioral or lifestyle components to the intervention, and you can see here in almost half of the studies that we evaluated, there was a dual diagnosis going on. And to remind you that a dual diagnosis, the way we define it in the study, took place when patients were both identified as having a conventional biomedical diagnosis, such as type 2 diabetes is the example I gave earlier, and at the same time they were being diagnosed, and that from another paradigm, whether that was Chinese medicine or Ayurveda or anthroposophy or another system. And that diagnosis, the non-biomedical diagnosis, was being explicitly reported on and evaluated for in terms of outcomes during the study. Now the figure on the right here gives you a sense of the way that we documented the intervention designs in the studies. And giving you a bit more of a close-up here, you can see how we've done this. So on the left-hand side, we have general traits that have to do with the type of intervention that's being studied. And on the right-hand side, we're addressing something that is, I think, fairly important in the whole systems designs, is how the researchers are handling the question of individualization. So again, just to reiterate, typically in your conventional classical randomized control trial, all the patients are receiving exactly the same intervention. Whereas here in our whole systems trials, we have individualized care being studied in a range of ways. And I'm going to go into some of those ways in a little bit more detail, but first I just want to draw your attention to a concept that we call manualization. Now, manualization is not something very specific to whole systems research designs, but the way in which our whole systems researchers used manualization is something that is quite important and unique. So manualization refers in a clinical trial context to the researcher's development of a standard or a standardized treatment protocol that can be used across the intervention that all the clinicians who are participating in the study will follow, and from patient to patient. It's kind of development of a manual or a to-do list, if you will, of how to treat the patient. Generally, these manualization protocols are developed by expert consensus, and that was no different in the studies that we evaluated. However, what was really distinct in the whole systems research trials was the way in which manualization was not the end of the story. Manualization was often used as a starting point for designing interventions that clinicians who were participating in the trial could then use according to their own clinical discretion to tailor or individualize the treatment to the individual. As you can see here across the pragmatic trials that we evaluated, there were a range of approaches that researchers used to this standardization or manualization question. So on the far left, we see that there were studies in which the intervention was sort of standardized on the whole, in which the clinicians were given a predefined protocol that they needed to follow with all patients. On the far right, we looked at trials that had what we call unconstrained individualization, which involves the clinician meeting with the patient and deciding entirely at their own clinical discretion how to treat the patient within the broad scope of their clinical toolkit. And somewhere in the middle, we have this manualization with tailoring, in which the clinician is given a set of predefined parameters within which to treat the patient, and within those parameters, there is scope or room to tailor the treatment to the patient. Now, as you can see up at the top, there are these two little boxes, tailored subcomponents or standardized subcomponents. There were again, a range of ways in which researchers approach this issue of individualization within the pragmatic trial context, which you can read about if you review the scoping review yourself. But just to note that there were some interventions that were on the whole standardized, but had small subcomponents that were that had room for tailoring. And similarly, there were some studies in which overall the design was unconstrained individualization, but there were some small components of treatment that were standardized. What I'm really wanting to convey with this individualization spectrum is that there are a range of ways in which researchers in the TCIM field can approach this question of individualization in a rigorous way in the context of a controlled trial, and that's really what we're documenting in the paper. And I'm going to give you an example, or a couple of examples now. Now, among the studies that we reviewed, we were not just looking at clinical trials and their outcomes. We were also looking at papers that had methodological components. So, for example, there might be a single trial or a single study that we looked at, but there might have been 4 or 5 different papers associated with that study, some of which addressed questions of methodology. So, for example, on the top right here, you can see one paper in which the authors are describing the process by which they developed a manualized protocol for massage therapy to be used in clinical trials in osteoarthritis. Now, of course, massage therapy is something that is often highly individualized. So how is it that a researcher could come up with a set of treatment parameters that are manualized or semi-standardized? This is what the paper reviews, and I encourage you to take a look at this kind of design. Even if you're working outside of the field of massage therapy, there are a lot of sort of important insights that are gleaned in that process, from that process in a paper like this. So this is also the type of work that's documented in the scoping review. Now, another study that I want to focus in on is one that involved both manualization and tailoring and the concept of dual diagnosis. And this is a study that I actually find quite exciting in its design, and I hope you'll find it so as well as we take a look. So this, the first paper that I'll be looking at in relation to that particular design was a pilot trial, and there was a subsequent trial that was also reported on in the scoping review. And this was a study that used traditional Chinese medicine for the treatment of temporomandibular disorders, so disorders of the jaw. And it was a pragmatic trial, comparative effectiveness trial. And the Chinese medicine interventions were compared with naturopathic medicine. So it wasn't usual care per se, but it was two different TCIM interventions going head to head in the design. What I'd like to show you here are the ways in which the trial researchers managed the principles of dual diagnosis and manualization together. So what you can see is that the dual diagnosis refers to, on one hand, a biomedical diagnosis of temporomandibular disorder, and on the other hand, every patient who entered the study was given a distinct Chinese medicine diagnosis, or a syndrome diagnosis if you're familiar with Chinese medicine pattern differentiation. So you can see here on the left hand side of the slide, and this is just a short list of the range of diagnoses that clinicians who were who were treating patients in this particular trial could give. And so they include things like liver qi stagnation, liver blood sugar deficiency, liver wind, liver yang rising, spleen qi deficiency, all this range of Chinese medicine concepts that are perhaps unfamiliar to the biomedical researcher, but very, very familiar to the Chinese medicine practitioner. And so the Chinese medicine practitioners in the study were at liberty to diagnose their patients according to their own diagnostic system. And they could also provide a combination diagnosis that involved more than one pattern, which is often common. So someone might have spleen qi shu or deficiency and liver qi stagnation at the same time. All the clinician needed to do was to document the diagnosis that they were giving to the patient with a temporomandibular disorder. And then as far as manualization goes, the clinician was given some general parameters to define their treatment. So for example, if the patient, as you can see on the slide, received a diagnosis of liver qi stagnation, they might be they would be at liberty to choose points including gallbladder 41, gallbladder 40, 34, liver 14, and liver 13. And they didn't necessarily have to use all of those, but those were the points from which they were recommended to choose in treating the patient. And this is a multimodal trial. So what that means was it wasn't just acupuncture being delivered to the patient, but also Chinese herbal medicine. And again, with the liver qi stagnation diagnosis, the clinician had some choice. They said, okay, they could choose between two different formulas, Shaiyo-san or Chaihu Shugan-san, which are both, if you're familiar with Chinese medicine herbalism, you know that those are both formulas for liver qi stagnation, but for different variations on liver qi stagnation, if you will, as far as a diagnosis goes. So in this trial, you can see that the clinician had quite a lot of liberty to determine how they would treat the patient, but that liberty was within these semi-standardized parameters that were predefined by the research team. Now, just as we finish talking about this particular trial, I want to draw your attention to, on the bottom left, you can see there was a follow-up trial, if you will, that used a similar design, but this time compared treatment from the Chinese medicine approach with a more usual care treatment, which was psychosocial care. So you can see there's different ways to do this whole systems design. And on the far right of the slide, just to show you some of the ways in which the researchers were documenting the diagnoses of the patients. You can see sort of percentages given in terms of how many, what percentage of patients received particular Chinese medicine diagnoses. And all of these factors were factored into the analysis of the trial results. So something I do want to mention is that these kinds of designs that we're talking about, these whole systems, multimodal, dual diagnosis designs, these are definitely not the norm across the 13,000 acupuncture studies that I described earlier on, right? This is really a minority of a small minority of studies that are using these kinds of designs that really aim to accurately represent the paradigm from which these practices are being delivered. And that's really something very special about these whole systems clinical trials. Now, of course, the real question is how were the researchers evaluating for patient outcomes? Now, we noted earlier that within the conventional classical randomized control trial, it is often objective measures such as blood markers or other measurable sort of physiological markers that are most highly valued, but there has been this movement increasingly within the biomedical world towards use of patient-reported outcome measures, or PROMs, within clinical trials. And this is very much what we're seeing within our whole systems research trials as well. The widespread use of patient-reported outcome measures, especially those that measure the patient's perception of their symptom severity, also issues around quality of life. And there are also some studies that are using what we call patient-generated outcome measures, where the patient defines for themselves what it is that they're hoping to see improved, and then over the course of the trial at different intervals, those outcomes, the patient has a chance to evaluate them themselves. You can see that often the outcomes were measured before and after, sort of a pre and post intervention. There are, in almost 2/3 of the studies we evaluated, there were also intermittent measures, sort of over the course of the treatment. Patients were also asked to evaluate for outcomes, and in many studies there was also a post follow-up. You can see most studies also did adverse event reporting, and there was a portion that included qualitative methods and economic evaluations, as we discussed earlier. Now, if you'd like to get a much closer look at how the outcomes were measured across our studies, the studies that we evaluated in the scoping review, you can take a look. This table is straight out of the review itself. And if there are particular types of outcomes that you are looking in your own trial to evaluate for, you can find here some trials that have done similarly. So in the interest of time, I'm going to leave it there as far as analyzing some of those trial designs, but would encourage you to take a look at the scoping review that I mentioned if you're interested in knowing more about the range of design options that really have been innovated over the last 2 decades by a small number of researchers working in the TCIM field, who I would suggest are really forerunners in advancing this idea of model validity in clinical trial design. So in sum, I just want to point out that whole systems research is a distinctive field. Now, although it may have features in common with the increasing trend towards pragmatic clinical trial designs, there are some very specific design features, including the dual diagnosis in particular, that are unique to these kinds of designs. As far as moving forward, there are some key issues. One is training a new generation of clinician scientists. And I say clinician scientists because one of the very important features of many of these trials is that they were not, strictly speaking, only researcher driven. They were also practitioner driven, because when we're designing clinical trials that are model valid, that really reflect the way that practice is enacted on the ground, it is really important to have the input of clinicians all the way through the research design process, and that's something that we saw across these studies. And so really, in training a new generation of researchers, it's important to consider that it may be practitioners or people who have a practice background who might be ideally suited to that role. In the scoping review, we talk more about the further development of complex analytic models that can really take into account a wide range of factors in a complex systems kind of way. And others and also starting to ask about what other kinds of measurables might be relevant, right? Are we talking about considerations around outcomes that are really specific to particular systems of care? We might want to consider outcomes around ecological impacts of particular therapies. There's a range of factors that really there's still a lot of room for growth in this field. So I want to thank you very much for your time. If you're interested in this topic or would like to reach me whatsoever, you can do so at the email address on the screen. And once again, thank you so much to the conference organizers for this opportunity. Take care. Hello.
Hello. Absolutely. The theme of innovation of methodologies is central to rethinking even what is evidence. That's why the paradigm of health promotion is central to the recognition of epistemology centered on individual, social, and collective care. That's why the sociological approach is fundamental to construction of this new epistemological pathway of care. We thank Dr. Nadine for her excellent presentation, and we will continue with the next panel. Thank you.
Thank you, Rafael. Now you continue with the next panel that I would like to share. But before, we have some notes important that I'd like to invite Natalia to just to have give some notes, and then you follow up. Thank you.
Muy bien, creo que a partir de ahora vamos a hacer cambio a español porque viene
I think that now on we're going to change to Spanish because we have a Spanish panel. I'll give the translators a moment.
Muy bien. Entonces, algunas...
All right, so if we have general recommendations for people that are connected in the YouTube channels, we have a YouTube channel for Spanish and a YouTube channel for English. If at some point, if you are in the channel you can hear different language, you'll see different links to go to the right channel with the right language. This summit has a 6-day lasting. Today is the MTCI focus, and afterwards we will have, or tomorrow we will have a full day dedicated to ancestry traditional medicine of the Americas, and Friday the 23rd will be dedicated to MTCI's articulation in health services systems, and the Saturday 24th of July we will be focusing on education in MTCI, and on Sunday we'll be closing down our summit talking about products in MTCI. Afterwards, the week after, those that have enrolled through the webpage will receive an email, which is an automatic email from the webpage of Event 3, where you will be able to find a brief survey of feedback from the 6 days of workshop. And after filling out this feedback, by the way, it's not an assessment or a quiz of each lecture, it's only a feedback for us. And after this, you will receive an assistance certificate. We wanted to do that because a lot of people are asking themselves that question, and we wanted to clear that up. Dr. Nadine is apologizing for not being able to join us here today in this conference, not even virtually, because she sends her regards, and we're sorry about any technical difficulties. Thank you very much, Ricardo. Thank you, Natalia. Now I'm going to share, and I will introduce the new panel. What we will be doing is to provide information about complementary and integrative medicine that were achieved in Central and South America. So our first presentation will be in charge of Dr. Mariana Cabral Schweizer from Brazil. She's an attached professor in the Sao Paulo Federal University, Unifest, with a PhD in the InfoImagine School from Sao Paulo University. He has two PhDs in Infirmary School from the Sao Paulo University and another from Catholic University of Portugal, with a Brazilian scholarship, and also from Brazilian scholar from University of Caliendo North, from Chapeo, with a specialist master in acupuncture and public health from the Santa Catarina Federal University. So Mariana, I think it's really important to have her as a part of the consortium. She's a researcher that has been working really hard in Brazil. Then we have Dr. Paulo Cáceres Guido, that I'm going to introduce after, and Dr. Mayacil Morales Perez from Cuba, that's going to have a presentation before all of the presentation. So we'll start with Dr. Mariana Cabral Schweitzer. Welcome.
Thank you, Ricardo. Thank you very much for this invitation and for this event. Congratulations to everybody that is involved. I would like to share my screen. I believe you can see it. Yes. Is that correct? So I was invited to talk about the traditional complementary integrative medicine research in Brazil. And this is because since 2019, we have been developing evidence maps together with CAPZIN and together with many researchers. And this gave us a very good overview about how is TCIM research in Brazil and also in Latin America. What we have today in this presentation will be some of the TCIM research obstacles that Professor Nadine just presented, and I would like to explore some of the topics. We will present to you some Brazilian TCIM research groups that was identified by ObservaPix, that is an observatory about complementary therapies here in Brazil with Professor Islândia, that probably many of you know about it. And we will present some of the evidence from the evidence maps related to focus countries, level of evidence and health outcomes in order to do some recommendations to develop TCIM research here in Brazil and also in Latin America. TCIM research obstacles are enormous. Professor Nadine just presented to us a very interesting scoping review where she presents the difficulties related to the different concepts and the different paradigms that are very related to the obstacles that we see in traditional complementary research. Usually this is the image we are related to science questions, and we are related to the science method when you think about the research development. But when we think about TCIM and complementary therapies, this process is a little bit different, and we need to have other paradigms to be able to develop all this research and also develop other types of methodologies, especially because most of the methodologies from what we say it is the quantitative research or what we say is hard science, they do not include the humanization process or the patient-centered process. And this is also part of the colonization process, and it's also related to capitalism and how we see the human being in this process. But all these go together to see the lack of funding to promote TCIM research. And the lack of funding is from the beginning to do the research and also continuously go to the publication process and the access to journals. So it is really interesting to bring up all these concepts and these obstacles because Professor Nadine just presented some of them. And here it is a space we can go further in the discussion in this panel. So in order to present the obstacles, we can also see that even though there are many obstacles, in Brazil, we have many research groups that are looking for complementary therapies. So the Observatory of Complementary Therapies, they did this research, I believe 2 years ago, and they identified 174 groups, research groups interested in TCIM or complementary therapies. And something that came to their eyes, it is that the object of research of these groups are initially, basically, the most common ones are natural resources that include medicinal plants, the use of honey, and all the natural resources that are a possibility to use in complementary therapies. The second most common object of these research groups were related to biofield therapies. And then we can see decent healing here, we can see emotional freedom technique, and we can see Reiki, for example. The third most common object were complex systems. As Professor Nadine just talked about it, it is what we say, and this is something that Brazil really helped to develop. It is what we call here the rationalities, medical rationalities that include anthroposophical medicine, traditional Chinese medicine, includes also other aspects that these medicines, they do understand the whole process of being ill, the relation with a cosmovision of the world. So the third most common topic of this research group were this complex system, or as Professor Nadine brought up, the whole complex systems. The fourth group were mind-body therapies, and this would include something that is very popular here in Brazil, that are the mind-body therapies or mind-body therapies from traditional Chinese medicine as Tai Chi, Qi Kung, especially here in the city of São Paulo, where I'm here right now. We have a very strong community that promotes these kind of therapies and praxis. And at least, but not at last, were the group therapies. And these would also include some of the complementary therapies that are from Brazil, as community therapy groups that are from state in Brazil, and they are Brazilian born. And these group therapies, they are very important to share narratives, to share the process of health and disease, and how this sharing really helps everybody to care for everyone as a community. So these are the main 5 areas where we have research groups here in Brazil. And it is interesting to see how these groups have been working in the last decades. Also, we have been doing evidence maps in relation to traditional, complementary, integrative medicine. And it has been a great experience. And Professor Ricardo, Dr. Ricardo, talked a little bit about it in the beginning of today. And I would like to point out the importance of developing the 6-step methodology that we just published in the Pan American Journal, together with all the researchers involved. And it is something that we are looking, it is a necessity in this area. Sometimes we need to develop methodologies that are specific to be able to promote and demonstrate all the research we have been doing, and people have been doing, researchers, clinicians have been doing, and be able to show this to practitioners and to policymakers, so they can have access to this information, and they see these are therapies, these are medicines that are evidence-based, and this will be an answer to the most common question policymakers have towards complementary therapies or traditional complementary integrative medicines. Is there evidence? And then with the evidence maps, we can answer them and say, yes, there is a lot of evidence. The library and the virtual library about traditional complementary integrative medicine identified over 1 million researchers in this area. And now we are being able to map this and put it together in an easy way and easy access to everybody. So we have today 10 maps that are already available at the library, and it is possible to access this information in English, Portuguese, and Spanish. And also we have 6 maps in development that hopefully we'll be able to make it available until the end of the year. And the focus of these maps are especially for practitioners and policymakers, but everybody can access the information and see the amount of evidence. Here in your left, you can see some of the themes and the areas that we have been doing these maps. And briefly, this is the methodology we developed. So we do a search in all databases. We do a very criteria selection process where all the researchers are involved and the specialists in each area are involved. We do a categorization process. And this is something that is very hard to do, especially because of what Professor Nadine just talked about it, that is about how we do categorize so many different researches and also methodologies. So it is very important to be able to see what exactly was the intervention in the research. So we ask everybody, when you're doing a research and after, when you're publishing your paper, you're publishing everything about this research, to be very clear, how did you do it? How was the intervention? How long it took? How was the method? Who applied, and everything about it. And also it is very important that you share the effect that you saw, that everybody share how the outcome was identified, how the outcome was related to the intervention. So we can...
Could you go slowly to the translators, please?
Oh, sorry. Yes, Ricardo. So the categorization process, it is very important. And for this, we ask all researchers to be very careful in the way they do transmit everything that they just found out in their researches. And then we go to a process of infometrics and to actually deliver the evidence map. And when we see all the information, that's when we can see the gaps and where we can see the windows, where we can see there's something that we still need to look for. And also we can see everything that is already a lot of evidence about it. And then we can promote the inclusion of this complementary therapy in all health systems. So let me share with you. So here you have the article, the scientific article, we talked about it, and here it's the website of the evidence maps in the virtual health library. So if everybody wants to take a deep look at everything. So what we have found so far, that we have over 500 outcome researches and 400 outcomes related to these evidence maps. And when we identify all the research, one of the things we identify is where was this research done, which country. And this map shows you where most of the research were from. So we have many research from Asia and from United States, I'm sorry, didn't show up, in Canada, and also from Europe. We don't have many research from Africa, and from South America and Latin America, we have from Cuba, Brazil, and Chile. So maybe it is an idea of that we need to invest more in TCM research here in Latin America. When you consider all the results from the evidence maps, we have 50%, over 50% of outcomes related to acupuncture, auriculotherapy, body practices, medicine, meditation, Shantala, and yoga, including Brazil. So we can say that most of the studies from the evidence maps, they do include studies from Brazil, but we lack other countries from Latin America. We have some studies that include Chile when they talk about medicinal plants, and we do have studies from Cuba that include yoga outcomes. But when we see all these maps, we see that maybe it is a place where we need to invest more in research. Well, we also look at the studies when we look for the outcomes. We look at the quality of the research. And then it is important to point out that for the first 10 maps and these following 6 maps, we were able to only include systematic reviews. So this is something very interesting. Professor Nadine showed us the pyramid of evidence, and the systematic reviews, they are in top of this pyramid. But it's important to see that this is not true for all kinds of traditional and complementary integrative medicine. But for this map, we were able to do this because there were so much studies. There were so much clinical trials that were enough systematic reviews that we could put together in these evidence maps. And how was the quality of these evidence, of these systematic reviews included? So as you can see here in this figure, we have lots of high quality, high level of evidence from one specific instrument that we use to analyze the quality of the systematic reviews included. That was AMSTAR 2. This was the instrument we selected. And then we have many studies from high quality, from moderated quality, and from low quality. And then we can, when we put everything together, we can see that many studies, they presented no effect, but very few studies included negative or potential negative effects, and this was common in high studies, quality, moderated, and low. And the big area that most of the studies included were about mixed results, mixed effects, potential positive effects, and of course, many positive effects in all the interventions that we first selected, that included acupuncture, auriculotherapy, meditation, ozoniotherapy, medicinal plants, body-mind therapies, reflexology, Shantala, and yoga. So you can see distributed in this image how many studies from high, moderated, and low quality were included. So this is to help us to understand the possibilities related to the evidence maps. What we can also see is the outcomes. Most of the outcomes were related to physical and metabolic effects. And they were also, in second place, related to mental health. And in third place, with aspects related to vitality, well-being, and quality of life. So we can see in these two figures how many systematic reviews were included in every map, including for these interventions, and how many systematic reviews were included for these 4 areas where we put the outcomes together. And then when we put all the interventions together, we can see how they were affected, how their effect was positive or mixed or not for chronic diseases, for pain, for vitality, well-being, quality of life. And these are the areas we see the most use of complementary therapies. So this is very interesting to share with everybody and to point out the importance of really showing the outcomes that were identified in these studies. So to finish my talk, I would like to point out some of the recommendations that we can do when we think about the evidence and how to develop the complementary therapies research in Brazil and also in Latin America. We can see the importance of an adequate description of the intervention. So not only to tell that it is acupuncture, but how were the needles, the points that were used, how was the process, and everything related to the intervention. Also, it would be important to do some kind of patronization for the health outcomes, because some studies, they only put out that the effects were interesting to mental health. But what exactly in mental health? Was it anxiety? Was it stress? Was it depression? So as much as it is possible to describe, it is better when we put all this information together and present an overview of the evidence. It is also important to show how the effect was identified. It was through a process, some kind of checklist or a specific instrument, how the effect was analyzed of the intervention related to the health outcome. Because once we can see this, it is easier to present to everybody. And then I would like to point out some checklists that are all available in the Equator Network that can help everybody that wants to do research related to complementary therapies, because they have over 450 checklists, instruments related to health. So if you want to do a study about moxibustion or acupuncture, they do have a specific instrument that can help you to better describe all of your research. So maybe you can take a look at it. And of course, we would need to include more countries and researchers from Latin America, because we need to show what we have been doing, everything that we've been doing, that we've been listening during this day in the panels. So to include more the countries and the researchers from Latin America, and stop the metals law, that it's not the top here, but we need to present what we have been producing. And in order to do so, we need to promote research funding opportunities. We have been seeing how these have been working in other countries, and maybe we can work together to promote research fundings and then the opportunities to develop research related to MTCI here in Latin America. And also, never forget to invest in humanized methodologies, because it is not something that we can be far from when we are studying complementary therapies. And usually some methodologies, they do not include this aspect, and it's also very important not to forget it. So thank you very much. I'm really sorry for the translator. I do tend to speak very fast, but I'm here to answer any questions.
Thank you, Mariana, for your very important presentation. And just to audience to know that later we come back to the theme of evidence map during the presentation of the consortium, where Mariana worked in this important project together with the Virtual Health Library, the BIREM. And now we'll follow with the Paulo Cáceres Guido. I will present him. Just 1 minute to. Paulo Cáceres Guido belongs to is the chair of the Integrative Medicine unit of the hospital, pediatric hospital, the biggest hospital in Argentina, Professor Don Juan Garrahan. He's pharmacist and specialized in hospitalar pharmacy. He's professor in pharmacology in the University of Buenos Aires and the Maimonides University as well. He can explain more about your background, because it's a big, have a lot of publications, and also belong to the TCIM Americas Network. We belong to the same group. It's an honor to be partner of him. So thank you, Dr. Paulo Cáceres Guido. Welcome.
Muchas gracias, Ricardo. Muchas gracias.
Thank you so much, Ricardo. Thank you for the invitation to participate in such an important event. Well, we're going to tackle, just a second, please. There we are. We're going to address some research experiences in TCIM in Argentina. We are also going to partially discuss something which relates to other areas in the region, in Latin America and South America in particular. Traditional, complementary, and integrative medicine in Latin America have a strong tradition, even during pre-Columbian eras, especially in relation to ancestral cultures. Currently, we need to be very clear that this is extremely used. There's an extreme use for this, because outside the domains which usually calls to this sort of academic events, it may be supposed that this is not so. But we estimate that today in Latin America, more than 400 million people make use of some sort of TCIM in primary care, where probably this is the most important, as well as under many other types of pathologies, especially in grave or very grave pathologies, which is why we will later describe some examples of some of these grave or serious pathologies. quality of health research when we compare conventional medicine against TCIM. Before all, we need to be clear that within the field of TCIM, uh, there's mostly there's very little research, and this is mostly in terms of quality than quantity. I'm talking about preponderant medicine or the so-called biomedicine. As was partially described, if one seeks specifically efforts published in Medline or PubMed, around 0.1% of research in health in Latin America is regarding TCIM. This is a figure which is shocking. So this means that around 99% of research performed in the whole of our region is regarding conventional medicine. So yes, in this sense, we have a very similar percentage in Argentina, where we have, well, in Brazil, excuse me, more than half of research. And then in Argentina, there is much research as well, especially regarding medicinal plants and others, as was mentioned in Chile, Cuba, and other countries in the region, approximately 1/5 or 20%. It is also important to have clear that there is, and this was partially discussed several minutes ago, but it seems very important to me to point it out once more. There is a publishing bias, as it is called, typical to TCIM, which means that during research on conventional medicine or biomedicine, there's usually more positive results published. So for therapies which have provided very good results in important publications. However, the second point here is that in research regarding TCIM, much more negative results are published. So when we do not have good results, when we have negative results within magazines of medium to high impact. So in other words, there's much more impact from negative impact from TCIM than positive results. And in turn, of course, there's much more impact from positive impact from conventional medicine than a negative one, which is usually published in very low impact publications, or often is not even published at all. So let's move on to an example, as I was saying, which seems interesting to me for the region as pathology of high use with regarding TCIM, which is cancer. Cancer in the Americas, here we have some figures which show that the most common ones are prostate, lung, breast, uterine or cervix, colorectal, and also stomach cancer, although there are also some minor ones. But they are in turn, apart from being the most common types of cancer, they are also the main causes for mortality by cancer in this region. The use of TCIM in Argentina, adults with cancer employ conventional medicine in general combined with non-conventional. So in other words, with TCIM, approximately in 90% of cases. In pediatrics, the prevalence may be somewhat less, perhaps similar to what we saw before, around 47% of oncologic pediatric population employs combined therapies with TCIM. There are many types of, many different types of therapies. This has been seen before, but we could point to therapies related to diets or nutrition, plants that we call medicinal plants, but they are actually plants where its employment is for medicine and many other types of treatment. Here, it also mentions energy therapies somewhat further down as well, and many others in relation to traditional medicine, especially Oriental or Eastern ones, such as yoga and several others. Now, the use of TCIM in oncology patients, according to a survey in the city of Buenos Aires, and here when we're talking about a survey, we're already speaking about one type of research because a survey comes from, well, specifically, it is a sort of research which often, even when it might have a limited scope, it might be very useful to understand the terrain in which one is working from the clinical perspective and the terrain in which one can deepen further from the perspective of actions in TCIM. So we say that around 90% of patients from these hospitals, which are four very important hospitals in the city of Buenos Aires, which also receive patients or admit patients often from the rest of the country who use some sort of TCIM. So note here that splitting them into oral therapy, religious ones, and several others, among oral therapies, we have those which serve to eat or to drink something, but insects are eaten, fire ants, beetles, wasp wings, boiled cow hoofs, scorpions, ants, and teas or infusions are drunk from aloe vera or nuts, bark, tree barks, fungus, or even urine or a mixture of vegetables. Some of these mixtures include alcohol as well and honey. Now, regarding religious therapies, curation words, praying to the gods, lighting candles, and also pilgrimages. Now, regarding many of these, research, there is research performed, but especially to those associated with point one, there is no research, basically nothing, very little, except, of course, those related to medicinal plants or phytotherapy or phytochemistry, of course. Now, other types of research that we performed several years back, also through surveys specifically to nursing units in hospitals for reference and diversion. Around one in every three patients with cancer in Argentina are attended in the Garajan Pediatrics Hospital, and this through the following results. The perception of effectiveness of use, most of the staff, the nursing staff understands in 75% that the patient feels better. Now, who does it depend upon for a family member from the cancer patient for them to be able to start therapy with TCIM? Now, this is split mainly between family and friends. So, in other words, when a patient is going to employ some non-conventional therapy, in general, um, the opinion of family as well as friends is very influential, not so much from doctors or other health professionals, and not so much their own decision, which often in this case is mostly children. And finally, it was asked to staff, the nursing staff, whether they believed that it was convenient to integrate traditional medicine and complementary medicine to conventional medicine, and more than 90% of the nursing staff agreed not only in integrating it, but also to deepen in more in knowledge on what this is about, because we know pretty well that there is much is not known on the issue.
Making a balance of what the types of articles of MTCIs and research in cancer in Latin America will be ending up by realizing that if we only look for Padmel and Medline facts in Argentina, and this might serve you as a standard example like we've seen before of a country of the region. And we see and we find preclinical and clinical tests and trials in MTCA in cancer, a pathology of one of those where the MTCIs are used in a greater proportion. And there are also matters of original research, excluding reviews, meta-analysis of palliative care with repetitive results, etc. So we find that in the last 30 years, only 17 articles of research were published. So at all lights, this is a reflection of how little MTCIs are researched and high quality or the quality needed for these articles to be published in Medline magazines or Padmill magazines reviewed by peers. And this is also really thrilling. And that has to alert us as a community of professionals of health and researchers in the region in these topics. So actually, in Argentina, we can see that there's none or maybe one or maybe two articles per year. There's only a few, almost nothing. Actually, in Argentina, most of our works are published or in the Buenos Aires city or in the province of Buenos Aires or in Cordoba, which is a different important province, and different groups in the Rioja province that's not so known, but it has a special interest in publishing this type of work and working and publishing.
En general, esto sale de investigadores, ya sea de...
Overall, this comes from researchers, being from the university or from professionals that are dedicated to this. In a few cases, they come from hospitals. That means that those hospitals where patients go to, that's where there's least research being conducted. That's another important thing that has to call to the reflection or to our thinking, especially in MTCIs, which is really important that university and investigators, researchers step foot in hospitals and for hospitals to be able to go out to research centers to deepen into the serious research that there's out there. There's a few collaboration with the exterior. Only one four works are with collaboration with countries abroad from Argentina, of course. And when we're talking about different continents, we're talking about Spain and Europe because of language, maybe US a little bit, India, Brazil, and Chile. When Argentina works alongside different countries of the region. Most of us were talking about the works being able to be conducted through medicinal plants. These are the magazines where they are usually published: phytomedicine, phytotherapy. We talked about natural products. We talked about a lot of it had to do with diet. So that's why we have associated magazines with the natural products, nutrition, into some immunobiology ones, and of course, ethnomedicine or ethnopharmacology. Few of them of different kinds. Let's remember that at Padme, we have over 5,000 magazines where it's possible to publish. The majority of them are works on animals. The majority of them are on cells, a few of them on animals, and most likely in mice. And we work with many of the cancers that are the highest occurrences in the region, as we've seen at the beginning. We are going to be rounding it up with MTCIs in cancer in Argentina and in Latin America. Hundreds of studies describe patients with cancer and MTCIs, and this is not bad, but it would be good to move forward towards a different type of terrain that would be researching by the MTCI, the qualitative research, meaning that just a few were taken into account. Quantification, variated and resources of MTCI are a part of this study. And these are researchers that are quantitative, that based in anthropological advances and through ethnographic methods, we can assess the type of therapies and the types of disease and illnesses that these therapies are used onto. This happens especially with cancer. There's a lot of research, and this is a part of what we were showing in the previous lecture. Most of these works are presented in congresses or theses that are presented completely, and they are only available in websites of universities, local magazines, and usually only available in Google or Google Academics, but not regularly, and they're not regularly published in magazines that have to do or that are indexed in Medline or Patna. Most of them sadly have a lot of problems, methodological problems, and many of them really grave. Only a few researches of assessment, like we said in MTCI cancer, is published in magazines, Medline or Palbe. Just to finish up, we have three conclusions with some of our perspectives. And I'll read it so everyone's clear about it. The formal structures of investigation and the national policies of research in Argentina and also in Latin America overall doesn't generate significant incentives to make long-term studies or research and of a high impact. That's why the reason that generally one of the main reasons why we don't get that much research done. Second of all, and given the high frequency, as we've seen at the beginning of use of the MTCI practices, is necessary for its effects, therapeutical and adverse, to be known better through research studies that are well designed. And third, we need to take into account the concept of integrative medicine or integrational as associated in research to this concept, which could probably improve the patient's attention and optimize in therapeutic results. Let me say goodbye with the first Science Nobel Prize, an Argentinian guy, Fernando Jose, in 1947. He said something like among the lines of, well, this is fitted for our matter, but it's almost like that exactly. Latin America is far too poor a region to give himself the luxury of not investing in research. And contrary to what many think, investing in research is generating development across in all senses of the word, of course, at the sanitary level too. Thank you very much. That'll be all, and I appreciate the time that I was given and the attention. Thank you very much.
Gracias por sua muy importante e brilhante
It's
apresentação.
been a really important presentation. And we have at the end more discussion about this.
Sorry, I have to shift to English. Now you have the presentation from Cuba with Dra. Mayazil Morales Perez. Just 1 minute to share the screen. Dr. Mayazil Morales Pérez é diretora do Laboratório Central de Farmacologia da Universidade de Ciências
She's the director of the Central Lab of Pharmacology in the Havana, Cuba, community doctor with the management of brain. And she's a doctor in bioenergetic medicine, specializing in wholesome medicine, pharmacology, and with a master in epidemiology. She's the director of Central Lab of Pharmacology and executive secretary of the sector program of natural medicine research and traditional medicine since 2020 till currently. And for this presentation, we have a video which will open our floor for debate. Thank you. Please go ahead, Dr. Mayazil. Good morning. We say hi from Cuba. My name is Mayazil Morales Perez, and I'm here to have a little chat about the Cuban experiences in research on traditional medicine, complementary and integrational. We'll be talking about what has been Cuba in this last few years in the research program of traditional medicine and the main result of impact that we've had and we've obtained for the Cuban health.
Sí, bueno, para hablar de las experiencias de investigación.
Ready to talk about the experience and research of traditional medicine and complementary medicine in Cuba, we start out by saying that since 1978, the World Health Organization recognizes the importance of traditional medicine of the diverse regions and of the different cultures of the world. In responding to this summon, the government started to send funds for the development and to start this mode of work for the health systems. Among them, the World Health Organization launched a strategy on traditional medicine in 2014 to 2023, with which we developed a response to the solution of the Worldwide Assembly on Traditional Medicine. Right now, The objective was to provide support to the member states with the means of taking advantage of this choice traditional medicine and complementary medicine, facing health as well-being and the key focus of people. And that should also be promoting the usage of these modes through the regulation and investigation, research, and the allocation of products for professionals and health system practices in each and one of these sectors. So for that, the strategy had the focus of developing policies that can be used in this mode for the maintenance of health and for people's well-being. It was established in four main goals where we can identify the access to improve availability and accessibility of traditional medicine, especially for the poorest people that we know already could contribute to the only therapeutical input and the rational use of causality or cases for the development of such and this managemental use that can be achieved from the point of view of the professional and of users as well. We will develop as well policies to the development and the application of guidelines that can integrate traditional medicine in the different health systems. And also one of the, oh well, I think all of them are important, but something else that's important is that it is focused and to that all of this methodology that can that we can develop is safe and with enough quality that's required for each and one of them, taking the base of the spreading out of the knowledge through the research that we conduct. It's known that across all of these and during all these years, the advances that were presented are important and they were put into evidence in each one of the member states. However, it's not true that there's still a diversification in Cuba. Traditional medicine, it's considered of national authority and the Cuban government alongside the national health system has taken upon the task of consolidating this type of medicine as a therapeutic alternative, but rather as a modality or mode that is a part of the therapeutic approach. And for that, we've approved certain standard or certain guidelines that are focus into the development of this type of programs like medication program where we achieve the creation of a basic chart for natural medicine where we have currently the list of products that 111 of them are of local production, 61 of them are of industrial production. And we've also announced a production plan to avoid the development and the consolidation of natural medicine and traditional medicine, where we can establish these actions linked especially to the ensuring and the acquisition of the commercialization of natural resources. We can also respond to medical attention with teaching, training, promotion of health control, and assessment of compliance of these plans, especially with taking enough importance and giving enough importance to natural and traditional medicine of each region. And for that, we've created in the Central Lab of Pharmacology that from the beginning was loaded with the management and coordination of the different researches and the different methods of natural and traditional medicine because it's well known that we have a huge range in culture of natural and traditional medicine usage, not just in Cuba, but across the continent that and that we've seen fed during migration with different influences from different cultures. With that, because of this, the Central Lab of Pharmacology started and thought of it itself as the manufacturer or carer or gatekeeper for this traditional medicine to care for all this traditional knowledge that we had in existence about natural products. So at the beginning, we started out as a national program of research for medicinal plants at the University of Natural Capital and Medical Sciences of the country. But if it's true that since 1990, the amount of investigation and research in this sense was really scarce, then in 1991, the policy of the country itself deepen into this type of research and to allocate more resources for the creation of the National Plan of Research of Medicinal Plants through the Ministry of Public Health. And in this stage, the main impact that we had on health was that we achieved to validate from the point of view of safety and quality for 40 national products that were in the network and allocated for that point. Known already as a RMI program for traditional natural medicine in a period of 1997 to 2006, we started to go through different changes across and everything that's related to research of traditional medicine in Cuba. Because, you know why? Because we started for the first time to talk about regulation of this type of research, and if we develop trials under that sense. During 2007 to 2011, the program was condemned by the National Center of Traditional Medicine, and then in 2012 it comes back again and it goes back to the National Pharmacology Center lab. And that's why from this point on, with a national program of research, with a greater certification and greater relation with different sectors, not just being implicated in the Ministry of Public Health, we started getting involved in the industry of regulation. And we made a series of researches that were rather important that came up to be into the introduction of more products of natural origin to our own charge of basic medication. And that's what we're taking advantage of to the methodology of traditional medicine. What happened in 2014? Given that there was a strategy of the government that we wanted to transform through the technology and innovation institution. And from this point, the lab started to acquire the category of innovation and research center. And that provides it more prestige, more validity to all of the researches that are conducted and that are reviewed and that are coordinated from our center. We have the Sciences Center, which is carrying out the whole process of transformation. And that takes us to the reorganization of the system since 2018. That would generate a public policy that will look for integration and industriality for research. And from 2020 on, we had an update in the structuration of research programs that go through this sectorial type of program from the Ministry of Public Health and can be updating its research and can amplify the existence of different approaches of medical treatment with general evidence that can be consolidated in the establishment of this therapeutic method within the system of health to improve the quality of the service of medical attention and of the government and of the way that the population is receiving its medical care. So with the national and traditional medicine that we have in Cuba, which are approved already through the system of health, are identified in this slide right now.
Nuevo programa de
And we
investigación.
can make this a new research program. This research program can be updated and will establish itself as a research point because when there's a line where we can establish this research, biomedical research and sciences, contributing to amplify the theoretical framework of traditional medicine. And there is the clinical research established to assess quality of medicinal plants and natural origin products and with the different modalities of therapeutic mode of traditional medicine, getting to know the active means or the active methodology. But we also look to for clinical trials to reassure the therapeutic modalities of traditional and natural medicine with the means of establishing this type of methodology through the pharmacological research of products and of each one of the modalities of traditional medicine. Also, and we look after the assessment of technologies for production in the processes related to the different unnatural origin drugs with devices in the therapeutic methodologies of traditional medicine in general to establish the information regulation in the national level natural medicine with the means of offering the traditional and specialists of health enough readings and enough information for the backing up of theoretical frameworks that will back up any treatment and to generate research and services system in therapies, education for health and so on, and of course communication about traditional medicine, including the use in the information and the education of an audience. So in this sense is that we've been developing a whole task that's being slow paced, but we have different masters and PhDs that come out of these lines of research, even in existence in the program for the spreading out of the results for this research. As for education to the assessment of insurance programs and consulting programs for the public itself. So different prioritized themes which cover the whole additional of focuses that are going to improve public health, public research on clinical health, with the commercialization research, the assessment of all of this technology that we use nowadays in traditional medicine, as for the development of new technologies that are linked to this same one, always taking into account what mandates in a regulational framework and correct management of this information without taking into account the information of those that consume, spreading out and social communication of each and one of these results and each and one of these methodologies. And how much impact did it have on this whole research program throughout these years in our structure? Well, in Cuba, the first steps that were taken in regards of investigation related to traditional medicine were to, or we started out with the making of the pharmacology lab, and since 1986, the Central Lab of Pharmacology is collaborating with the TRAMIL program, which we know is leader in this research with medicinal plants in Caribbean. With the same, we've developed different type of research and how the results were published in national and international magazines with a lot of impact and a high level of impact, especially looking at the effects of our lab that collaborate actively in the making and the updating of the Caribbean scope. In Cuba, we've also developed different phytovigilance and phytosurvey studies on the use of each and one of the methodologies of traditional medicine. One of the main findings that we had was in a study that we conducted by Luis Salvador Garcia Milani and collaborators with, they found that from 2003 to 2010, there was 908 adverse reactions produced by reported phytopharmaceuticals under the pharmaceutical surveillance, out of which 80% would be of an age group under 15 that use some type of phytopharmaceutical. And we saw in this study that 100% of the adverse reactions that happen in under 1 year are considered avoidable. That's why we shouldn't stop taking into account that if it's true that we are considering this to be harmless, sometimes this type of prepping are sometimes not. And that's why it carries with it the risk of provoking adverse reactions as a different conventional medication, but also it's implicit the load and the risk that it has of provoking reactions with different plants. Like we also have this cross medication problems with traditional medicine. We've had a lot of uh, literature about it and to be updating our medics constantly and professionals. We have this literature that is of almost mandatory consultation in the phytopharmaceutical institution or Roscoe of natural products, but also we developed these researches of Cuban phytopharmaceuticals based on the evidence that we had regarding the use of this. And we have a methodological guide that states all of what's referent to research and self-surveillance on products of natural origin. And we've conducted, as I've mentioned, many types of research. Actually, this type of research in our country, so far, uh, adds up to 24 doctoral theses, and some of them under the methodology of traditional natural medicine. We see that phytotherapy is the response or the answer, or a more important place within all of this research, with 62.5% of them being phytotherapy, and especially these theses where the traditional natural medicine is known or is studied in a more broad manner. And then, as a methodology, we have homeopathy. Then we have a series of clinical research that was conducted where we identify some of the methodology of traditional medicine, which are the center of a matter of trial. And so far, we have registered those in the public records of clinical trials, 11 clinical trials, where the majority or the highest percentage of them corresponds to developed trials with phytopharmaceuticals.
aquellos donde se utiliza la ozonoterapia.
And right after, uh, we have ozonotherapy. And this amount of clinical trial that we can find registered in our public records, out of it, 73% are related to research where we've used a methodology of natural and traditional medicine to face this problem. So currently, we have 36 projects that are in the making nowadays and that are part of this research program. Most of them have to do with phytopharmaceuticals, participated with 55.6%, and then we combine certain traditional medicine methodology and then also therapy, which has a different type of weight within the traditional medicine scopes in our country.
Para los cuales tienen el espacio para que todos estos resultados salgan a la luz.
So there are events presented here which have space for results to uh, be published and become socialized. We have BioNat, for instance, FAPRO Natura, scientific events from provinces from the Cuban Naturalist Bioenergetic Medicine Society, where each locality has their space to to divulge results. And this year we had a Natumed event where homeopathy had an important significance. And then CIPLAM, the Research Institute, the Francisco Moron Institute, who was founder of the laboratory. Also, our country has two publications for divulging all results, not only from within the country, but also regarding research in traditional medicine, natural medicine, and medicinal plants that may be performed throughout the world. The Cuban Gazette for Traditional Natural Medicine is published by the Cuban Naturalist Bioenergetic Medicine Society, and it is published in Spanish. And the official site, you have the web page shown here. And there's also the Cuban Gazette for Medicinal Plants, which is quite veteran. It recently celebrated its 25th year. It is published 4 times a year in Spanish, although articles in English and Portuguese are admitted. And this is also a gazette which presents publications which have solidity and maturity regarding their results, their research results. This was a presentation. This was an overview of the situation that that research on traditional medicine is in our country. Thank you so much.
Gracias pela. Sorry, to the translators, I will keep in English. Sorry. Now, to conclude that important panel about the Central and the Latin American experience in research, I have the honor to invite our colleague and the co-organizer of our Congress, Dra. Natalia Sofia Aldana. I will share the screen to present her. Dra. Natalia Sofia Aldana from Colombia is editor-in-chief of the Virtual Health Library on Traditional, Complementary, and Integrative Medicine of the Americas. She is also member of the TCIM Americas Network, and she's a physician who practices acupuncture and homeopathy, works like teacher in TCIM in different universities in Bogota, Colombia. She has been working in projects of public health with TCIM and also been working with indigenous communities and traditional health knowledges. She has been a consultant for the Pan American Health Organization, PAHO WHO, Latin American Caribbean Center of Health Science Information, BIREM. So, very welcome, Natalia, to present in this panel your experience in Colombia, and later on you have another presentation in the networks and consortium.
Gracias, Ricardo. ¿Me confirman si para los
Thank you, Ricardo, and please confirm whether it's easier for me to continue in Spanish.
Mientras tanto voy compartiendo las diapositivas y estoy atenta aquí al chat de WhatsApp, que me avisen, por favor.
Ainda não está, vai apresentar ainda.
Sí, todavía no se ve la pantalla.
Not yet.
Ok, un momento. Voy a dejar de compartirlo y comparto de nuevo, ¿ok?
I will stop sharing and reshare, all right? I think now it works. I will configure my audio once more. It is at volume max. This is what happens when I switch microphone. Is it better or?
Creo que el problema es que tengo los dos YouTube en
All right,
movimiento.
just allow me a second here. I was playing two videos, which was hindering broadcasting, so just let me try again. Apologies. Great, now there we are. Okay. Thank you so much. So I am going to briefly introduce an overvieu on research on TCIM in Colombia. This talk will have two parts. First one, where I will mention data of research data made specifically on alternative and complementary medicine, and later the studies from my colleague Paula Acevedo regarding traditional indigenous medicine. So the first research was developed along with two Colombian colleagues, Dr. Eduardo Balcan, Dr. Germán Benitez, and basically this research was its purpose was to seek what was happening in Colombia, as we have important or interesting history on the arrival of complementary medicine, but including this among academics happened more formally during the 90s, and starting 2005, consolidation started on postgraduate programs. So we wanted to know what was happening with research, and for this purpose, a review, uh, book review was designed with some spaces for biometrics. We did made an analysis of the situation, and we made a review of topics for that purpose. So first, we analyzed the context on what was happening at, worldwide, from different strategies and tools which had been strengthening spaces for implementing TCIM. If I'm going too fast, let me know via the chat. And how these same international bodies, by promoting articulation, their healthcare systems were also strengthening an agenda as to articulate and strengthen research spaces. It's this way that in Colombia, and well, briefly, Dr. Yvonne Diaz gave a brief overview on what in Colombia we know as complementary or traditional medicine from other countries. In our country, by legislation, it is mentioned as alternative and complementary medicine. The first to arrive to the country was homeopathics in 1840, and in the year 1970, neural therapy arrives, and more officially, proper or our own proposals for medical systems were developed, and clinic clinic efforts start. And then in 1993, health additional payment or supplementary payment health services were introduced. And then in addition to that, in the aughts, in public hospital spaces, they start to become included. And then in 2005, they start opening up in universities. Therefore, this is the context for the country and the situation. So, regarding or comparing to the situation worldwide along regarding these main research lines, which are basic sciences and how TCIM works, the issue of research that relates to the use in epidemiology, research regarding effectiveness, looking into clinical research, and integrative medicine based on evidence. We also considered within that research that there is a growing line which is not necessarily from health, but perhaps from different spaces. And this is regarding research from social sciences, how from medical anthropology, from sociology, a phenomenon of the use at other levels of traditional medicine is used or employed. Also, worldwide research had been promoted by specialized institutes and by universities with specialized programs and by hospitals which started to create specific working spaces on integrative medicine. So what did we find during the book review in order to find the Colombian context? That worldwide we've seen that most researchers find that there are situations regarding methodological scopes. There are many researchers proposing that they are not always able to find financing, because, and this is important because in Colombia, there's no financing of research in TCIM. It is quite difficult for researchers to obtain resources in order to perform their research. There are some research centers. However, there are many magazines which have a bias regarding TCIM methodologies, but also there are biases among university institutions and research institutes as well, which do not always allow to technical conditions proper for the effort. We also see that or find that there's much trained reviewers, but often they are not found in the spaces where research is being carried out as to be able to properly assess this research work. We also find that there are many doctors who are proposing precisely how these apparent obstacles turn into challenges as to strengthen research spaces in TCIM. In spaces such as these, well, this comes by Bishop Fonebo stating that there are moments of reflection on how to propose how to use research methodologies on TCIM in order to tackle complexity and regarding the very own paradigm that each traditional medical system has, or each complementary medicine, or each therapeutic method. And some doctors, as Bishop, propose the importance of not limiting ourselves to quantitative studies, but to see how we may perform research with two parts to it, qualitative and quantitative. Now, worldwide, what is observed is that by 5-year terms, we find that issues that are usually researched are regarding medicinal plants, inflammation issues, lumbago, articulation issues, quality of life, and later we have different magazines. And well, these are some of the issues or topics that are commonly observed. So in Colombia, we built two theses, one for research efforts with Dr. Gallego and Dr. Alejandro Oaxaca in 2006, and later we updated that information in 2011, no, in 2016, sorry, with the two colleagues that I previously mentioned. Now, for that purpose, we sought after publications on basic sciences, human sciences, social sciences, and health sciences that relate to TCIM in humans and in veterinary. We sought those researchers carried out by in Colombia or published research abroad. We looked for gray literature. This is understood as books with research results or thesis or academic literature that has gone through requirements from universities, but which basically, due to financial reasons, had not been able to a scientific paper or an indexed magazine. So we also excluded letters to the editor or other issues, and certain search strategies were built. We looked up different databases, and with a couple of variables, a matrix of data was built, and there we found that by 2016, December 2016, we found 1,146 efforts developed in Colombia regarding TCIM, finding that in 1980, there were very few, and seeing that after 2006, there's a significant increase in the number of publications with a predominance on academic publications and by 80%, but unfortunately only finding 15% of within indexed publications. After a quick review with the researchers themselves, who most of them are postgrad students, master's program studies and specialization studies, one of the limitations in order to publish articles has been the cost of $2,000 or $3,000 that must be assumed. There are some, in some cases, there were no costs for publication, but this was the main barrier, which is why many research results were left published in a thesis at university repositories, and this did not turn into a paper that could be identified by other countries. within other searches. We found that during the period 1980 to 2010, we had a total of 83 articles in indexed magazines. And in the period 2011-2016, so a period of 30 years comparing to a 5-year term, we see 83 now, which somehow was a positive result because it took us to understand that if in a 5-year term we had achieved the same as in the previous 30, then we have we have our faith set in that we will be able to find an increase in percentage of information on indexed magazines by the end of 2021. We find that what is most researched in Colombia is homeopathy, Chinese traditional medicine, herbology, phytotherapy, followed by Ayurvedic medicine, vibrational therapy, mind-body therapy, manual therapies. And among manual therapies, we find homeopathy. And from that number of publications, which is 170, more or less, for indexed ones, 58% is published nationally and only 41% abroad. In gray literature, this more or less keeps the same topics distribution, and this is most, well, thesis, books, and there's very little percentage of papers. So this is just to tell you a little on the research trends. I'm checking my time now. So what we see is regarding therapeutic modes is, and what I mentioned is that there's a point here, and that homeopathy is the first complementary medical system that is being researched, but we noticed that in the 5-year term 2006, 2010, and then the 5-year term 2011, 2015, acupuncture and traditional Chinese medicine research increased, followed by vibrational therapies, research in music therapy. So we made an analysis by 5-year terms on index publications. We found this. This called our attention that most results are found under homeopathy, Chinese medicine, music therapy, neural therapy, reflex therapy, chiropractic, and phytotherapy. Regarding methods, we find that there is topic review research, and there's little research and methodologies that employ or apply experimental methods, and there's really no clinical trial carried out in the country. Now, in the group of Chinese medicine, we find that mostly there's research for acupuncture compared to Tuina, moxibustion, and Tai Chi. This is a summary of sorts. We have dominance of on topic or systematic review, and there's an interesting percentage of qualitative research. And under homeopathy, it's basically has the same results. So this is just telling about results on research that we performed, which took us to conclude that it's very interesting how when universities get into having postgraduate programs, and then Columbia education and TCIM is limited to health professionals, but particularly in 3 universities which have these programs for paramedics and only 2 for medicine as such. And we note that these universities within their postgraduate studies, they have research, but they favor scientific research production in the country. You also find that these same universities, by reviewing, we find that these same universities are who have created the research groups. We have the Manuela Baltar, RESUV, the Columbia Free University, Juan N. Corpus, and Universidad Rosario. I won't stop in reading the research results from each of these universities. And recently, ISEPA and under CEPAL, also there are research groups. Now, in general, we observe that topics that are most researched are pain, osteoarticular pathology, mental health pathologies, and that there is interesting research regarding epidemiology and lighting. So what we're suggesting is for universities that it would be important for them to better strengthen training, human talent, training more on research because there are this whole issue regarding difficulties that students also run into in order to publish scientific paper. And obviously, one of the challenges to overcome in Colombia is this issue on technical cooperation as to achieve financing for research, because this basically has made it so that most is limited to research methodologies, which is much easier to do, such as topic review or qualitative, and not so much clinical research as such, and also due to difficulties in having alliances with those hospitals. We also recommend that information on database should be visible, especially the ABS project that will be described further in the afternoon, helps to address this difficulty. And then my final 4 minutes, which I believe is what remains for me, I want to tell you about research results from Dr. Paula Acevedo, who performed research regarding what had been done on traditional medicine in Colombia. What she did was to review that by having 43 acknowledged groups or ethnicities in the country, with the whole issue regarding acknowledgement of healthcare systems, which has other guidelines from the Ministry of Health. Along with them, there is no knowledge on what kind of scientific topics are being worked on regarding traditional medicine research. So an analysis was performed regarding what is traditional medicine and cultural issues, intercultural issues, also how popular medicine is understood. And well, the question from this scoping review asked what was the scientific production and aspects researched in Colombia on traditional medicine, traditional indigenous medicine. For this purpose, some words of natural language was used, mesh terms were used, texts also in thesauruses from UNESCO. Also, there were restricted searches or queries on different databases, and by scope review methodology, out of 311 documents found initially, 42 were left for analysis, where a description was made on what each of them had. We found that mainly this is research of qualitative or ethnographic qualitative type with participant action, and some mixed ones as well. And well, that mainly these research groups from the University of Antioch, the National University, Cauca and Rosario universities, the Chocó Technological University, the La University, the Córdoba University and SEMI are the producers, and also with the Caldas University, the Bosque, Guajira, San Petersburg, the University of Chile. So what does this conclude? This research from Dr. Paula, that obviously there's this whole process of culturalization, that when people get into performing research, often or sometimes they get much into observation, but not including the community. And there's information lacking on students' training capacities, so that health topics in general from health professionals, we really have very little information regarding realities of indigenous communities in our country, which makes it so that topics are not tackled from health sector. This is usually tackled by social sciences with more qualitative techniques. So it is suggested to continue having exchange of knowledge with the communities and populations, and to continue working on methodologies that some research centers have generated in the country as to strengthen these spaces. So that would be the summary of what I wanted to tell you in these 20 minutes. The reflection is basically, or the takeaway is that there's much to do yet in Colombia on research. Research professors from all four postgraduate programs are putting more effort into improving students' training. However, we find limitations regarding timeframes for students, and especially financial limitations, because many of them want to propose other kinds of research which will imply different timeframes and financing, which is not always easy to obtain. What we hope is for these challenges to be resolved and for the country to increase its research on TCIM topics, which at the time have been already developed. Thank you so much. Thank you so much, Natalia. And now we, thank you so much, Natalia.
Go to the end of that panel with the questions, and even some questions are already answered in the chat. I'd like to come back to the questions because other people could hear. The first questions to Dra. Mariana. Which reaction and the medicinal plants, and which kind of plants were studied in that map, evidence map? And on another question, which medicine is most popular in Brazil beside the conventional Chinese with acupuncture, tai chi, or Brazilian traditional medicine, herbology, others? I think we can start with these two questions. Please, Mariana.
Yes, thank you very much. About the use of traditional and complementary therapies in Brazil, I answered in the chat, but it's very interesting to see that the most recent data about this in a national level, it was done in 2013. And then the researchers, they identified that there were differences between Brazilian regions. Brazil is very enormous continentally. And then what they identified, it was some patterns in the use of these complementary therapies. So one thing that they found was that women and older individuals residents in the south and north regions of Brazil had higher chances of using traditional and complementary therapies. And in general, the richest population with more chance to use homeopathy and acupuncture, and the poorest using medicinal plants and herbal medicines. The total number they showed was a prevalence of 4.5% of the population, which included around 7 million adult Brazilian individuals using complementary therapies. And it's very important to point out that since 2006, we have a national policy that includes complementary therapies, and today we have 29 complementary therapies included, that they have over 200 practices, for example, traditional Chinese medicine, and all the practices that are involved in traditional Chinese medicine, anthroposophy, or, for example, medicinal plants that we have also. It was very delightful to see the lists from Cuba, from Colombia, the importance of presenting. And also in Brazil, we have a list of medicinal plants that are recognized by the National Health System, and also many, many others that are still in research. So especially about the medicinal plants that were included, that included Chile as a focus country, it is important to highlight. I can put in the chat also the link to the article, the scientific article that presented, but included aloe vera, Canella officinalis, ginseng. These were the medicinal plants that they studied in this systematic review, and some of these studies included Chile. So it is very interesting to see how this has been growing. Thank you so much.
Thank you, Mariana. Now I will speak in Spanish because it's to all expositores, é uma consulta para os três expositores.
It's a question for our three speakers. Currently, how do you select each one of the ancestry or ancestral medicine for patients?
Bien, puedo responder sintéticamente.
I can respond basically in Argentina, we have only a few groups that work in this type of assessment. Generally, they're botanicals or they're biologists or from associated sciences to biology. And few times only doctors, but in all of the cases, they're ethnobotanical specialists or ethnomedicals or ethnopharmacologists. And those publishings that are published better are those that these researchers are doing in the same sites where they live, where people and indigenous people live, ancestry population live. They make surveys, they spend days or even weeks living there just to have a deeper knowledge and certain of information that comes from this population.
Gracias, Paulo.
Thank you very much, Paulo. I believe that I have an observation about Cuba. I don't know if our, but sadly, our Cuban speaker is not here to respond. Natalia, maybe you.
Yo tengo a Mayacil en el WhatsApp y entonces
I
envié
have
una
a Maya Sile in WhatsApp, and she sent me an answer to WhatsApp. And she mentioned that if in Cuba we have a huge tradition related to especially the use of herbal medicine and the derivatives from honey. It's true that this knowledge is accumulated and is transmitted from generation to generation, generating days of research. However, it's important for researchers validating scientifically uh, evidence to ensure efficiency of these therapies. And well, this is what she mentioned, facing the reflection of natural medicine. Yes, that's her response. Thank you. So I believe that we can just close this beautiful round table.
You have now an active pause with yoga. It's a kind of oficina.
Ricardo, hay una pregunta que leí aquí en
Ricardo, there's a question that I read here on YouTube. We didn't have it in the Zoom chat, but it might be valid. I'm sorry, I didn't look at that question. No, it's okay. We had it on YouTube. So there's a question here from Paulo. He asked about why in this panel of Latin America we have not included indigenous people, masters. Oh, I lost the question, but it was among the lines of why don't we have different Chinese medics that come from the line of the medics Ayurvedic? I'm homeopathist, and but in Colombia and all over in Latin America, apparently there's some efforts, and there's actually several efforts to undertake research on originary population. And tomorrow, several countries of the region of Latin America, or I'm sorry, across the Americas, will be sharing with us this type of experiences. Tomorrow, we will have, I believe, 20 guests that are from Afro-American population, from indigenous population, from the different ethnical groups. So I believe that tomorrow will be a day where probably that information will be nourished even better. But one of the thoughts and reflections that I was mentioning before is that we see that in the region, that unfortunately there is a predomination of research to be held over in the academic space, and there's certain limitations financially speaking, especially in many other countries of the region, and not just financial, but there's also um, educational training limitation. Even when we notice that some students that are not aware about how important it is to learn this on the pre-grade in across the areas of traditional medicine of ethnical groups like in our systems. This is something that we hope that the Americas region can improve on. I'm sorry, Ricardo, can I say something else? Yes, please. I understand the question, but also I see the summit or the summits overall is really, really inclusive, meaning basically didn't leave outside. Now, when we are talking about when we deal with explaining what we had or what we have now or what we are going to have in the future regarding research, well, sadly, members of originary population have not generated research, and that's what this table is about. If we had a master, a shaman, or a member of an originary community or ancestry that had conducted research or that had a clear concept on research that we conduct in a country or in the region, probably we could have had a space for that.
Gracias, Paulo. I'd like just to mention that Mariana wrote me to share that in September you have a Brazilian Congress, and one part of the one day you devoted to traditional medicine, but unfortunately it will be only in Portuguese. But we can share with you later. Who are interested, we can send it, the more information. Entonces, thank you very much. And now I would like to announce the next activity will be active pause with yoga. And who can put out these shoes? It's available to do this. It's better to do without shoes, but no problem if you can't do this now, just to follow. And you present a video, then you can follow. Thank you very much, and see you in some minutes.
Namaste. Mi nombre es Galerena y conmigo está Cintia Mejía. Ambas somos instructoras certificadas.
My name is Galena, and with me is Galejira. We are IU certified professional instructors, and we are really happy of being here today with all of you, the assistants to the second summit, worldwide summit of traditional medicine and complementary towards an integrative type of medicine. We know that the journeys of this summit are really long, just as our days of work is. And even if we're going to the office or we're doing telework, and what do we do when we are all day just sitting down in the computer? We start feeling tired, we feel our muscles getting sore, you feel a general tension and tiredness in your body. So what we're going to do now is a really simple practice that's going to allow us to stretch all of our muscles, stretch our spine, and work all across our articulations, and we can finally feel relaxed in a 10-minute period of time that we're going to be pausing. So we sit down. And the first thing that I want you to do is to think about how do you feel right now. Each one of the sensations that you have at this point. We'll close our eyes, hands in our lap, and we'll inhale. We'll concentrate in our breathing. We count till 5. We exhale. We'll do it 3 times. We inhale, and we exhale. Inhale and exhale. Now open your eyes. We can start working on our neck, which we regularly feel the biggest and the heaviest of tension. That's why we're going to inhale. And when exhaling, we're going to take our chin towards our chest, or trying to make it touch our chest. We inhale and we take our head backwards. We stretch as much as we can. We exhale, chin to our chest. We inhale, we go back to our center, to our core, and we exhale to the right. We inhale again, center, and we exhale to our right, trying and making and aligning our chin to our shoulder. We Inhale again in the middle, and we exhale to the right.
Inhalamos, volvemos centro y exhalamos izquierda.
And we exhale to the right, to the left.
Inhalamos, volvemos
We
centro,
inhale,
exhalamos
we go back to the middle, and when exhaling, we'll try for our ear to be parallel to our shoulder. Feel how muscles are stretching.
Inhalamos,
We inhale,
exhalamos hacia la
we
izquierda.
exhale to our left.
Inhalamos nuevamente,
We inhale again,
exhalamos derecho.
we exhale right.
Inhalamos, volvemos centro.
We go back to the middle, we exhale to the left.
Inhalamos, volvemos centro.
We go back to the middle, we exhale, we take our chin towards our chest, and we'll do a rotation clockwise.
Inhalamos,
We inhale,
exhalamos.
we exhale,
Sentido contrario, inhalamos.
counterclockwise. We inhale, we exhale to our right.
Inhalamos, volvemos al centro.
We inhale again, we go back to the middle, and we're going to take our arms to our chair sides. Now, inhaling, we'll be going to, or we'll take our arms up,
Procurando que queden paralelos a las
trying
orejas,
to get them parallel to our ears, palms out.
Exhalamos,
We exhale
silla,
without touching the chair.
inhalamos nuevamente,
We inhale again,
exhalamos.
we exhale.
Llevamos la pierna derecha,
We take our right leg
la pierna izquierda,
to the left leg over it,
manos
and
juntas
we'll
hacia el frente,
have our hands together facing front, and we'll inhale and we'll exhale looking to the front. Don't bend your back, don't curve it. You will look in front until you get to a point where you can't anymore. Don't force yourself. We go back and we go back to our right leg, and we do the same thing with our left leg.
frente,
Hands facing forward. We inhale and we come down, facing forward,
espalda bien derecha.
arched back, really right,
Inhalamos,
back. We inhale
bajamos.
and we come down.
Ahora, manos sobre las rodillas.
Now,
Vamos
hands
a inhalar y vamos a
on top of our knees. We'll inhale and we'll
la cabeza hacia
take our head backwards
sin forzar.
without forcing it.
Exhalamos hacia
We
adelante,
exhale
direccionando
to
la
the
espalda.
front, curving our back.
Muy bien. Inhalamos.
Very good. We inhale,
Manos a los lados de la silla.
hands to the side of our chair,
Dos pies hacia arriba.
and we'll take both feet up,
Al piso.
trying to get them parallel to the ground, 90 degrees.
Y exhalar.
We'll inhale and we'll exhale. Inhale
Exhala.
and exhale.
Una vez más. Inhala.
One more time.
Exhala.
Inhale and exhale.
Ahora hacemos rotación en el sentido
Now we do rotation
del reloj. Uno,
clockwise. 1,
dos,
2,
tres.
3.
Y hacia el otro lado. Uno,
And then facing the other side. 1, 2,
tres.
3.
Si es difícil hacerlo
If it's hard to do it with both legs, you can do one and then the other one after.
bajamos. Y ahora
We
nos
come
ponemos
down
de pie.
and now we'll stand up.
Vamos a abrir un poco las piernas.
We'll open our legs a bit.
Llevamos los brazos
We'll take our
hacia
arms
adelante a la altura de
to
los
the
codos.
front,
Entrecruzamos los dedos.
to our shoulders height. We cross our
Los
fingers.
llevamos hacia afuera.
We take him to the
Y
outside.
vamos a inhalar.
We'll inhale,
Los brazos hacia arriba, procurando
taking
que
our
queden
arms up,
paralelos a las
trying to
orejas.
get them as
Cuando estemos
parallel as to the ears. And when we're here, we get to the
mira un
tips
punto fijo al frente para que no
of our
pierdas
feet,
equilibrio. Esto es
and then look at a fixed point. This is a really good posture to improve balance and stretching our column. We lower our heels and we lower our arms to our side.
Ahora vamos a hacer
Now
una flexión lateral.
we'll make a lateral flexion. That's where we'll inhale
Derecho arriba.
and we take our right arm up, and exhaling,
Vamos hacia la izquierda.
we go to our left.
Inhalamos, volvemos.
We inhale, we go back,
Y repetimos
And we repeat this motion to our left. We inhale, we exhale. We go back, inhaling, and we relax. Remember that you shouldn't make any force or excessive force, or your body will let you know. And we'll take now our arms to the front. Inhale in. We'll turn to the right. We inhale, we go back to the middle, and then we do our turn to the left. That way, we are working our column completely. We lower our arms, and we'll go back to our chest. Right now, you are feeling how your whole body has worked in a really simple way, a really soft way also. This has no greater contraindications. You have to be conscious and aware about your body, the full awareness, attention to the moment. Forget about everything else and just focus in this moment. And just to finalize, we'll do again breathing in and out. You just close your eyes first. Then you can focus in what we are doing at this point. All of your attention should be focused in your breathing. We inhale deeply. We exhale. Inhale again. Exhale. We inhale. And we exhale. We open our eyes. And right now, you already feel relaxed, more at ease, with more energy to be able to carry on working. This is going to be really useful for you. I encourage you to do it every day if it's possible. Thank you very much for your attention and for being here in the second World Summit. Thank you very much. Namaste.
Thank you very much, Galia, to conduct us. You are with a lot of energy now to follow the Congress, the second World Summit of TCIM towards the integrative medicine. Now you have our last panel, and then we have the speech of John Adams just after. And who will moderate that panel, it's Caio Portela, co-chair of the Brazilian Academic Consortium. It's a pleasure to be beside him. We're together here in Brazil. So we can follow now. Thank you, Caio.
Thank you, Ricardo. Hello, everyone. It's an honor to coordinate this panel that contains so many important players in the field of TCIM. And I have been inspired to see this strong movement of organizing and networking, promoting research, professional organization, and integration in collective health of the integrative approach. And our first speaker of this panel that I'm to speak to share experience of collaborative work in research networks in TCIM is Holger Honders. Holger is the director of the Dutch Consortium for Integrative Medicine and Health. He is an integrative psychiatric senior research and director of the Center of Integrative Psychiatry in the Netherlands. Holger is research in the area of the mind-body medicine, spirituality, integrative medicine, and mental disorders. Holger, Please share your speak.
Buenos dias, or good morning, afternoon, night, wherever you are on the globe. I think people from many different parts of the world are joining in. Thank you very much for your kind invitation. I'm very happy and grateful to be part of this important event. My name is Rogier Hoenders. I am a psychiatrist from Holland, from the Netherlands. I've been working for 23 years in conventional psychiatry in a large non-academic hospital. We have about 4,000 employees. We serve about 30,000 patients. And I'm the founding director of a very small part of this hospital, which we call the Center for Integrative Psychiatry, which is basically about implementing integrative medicine into conventional psychiatry. This has been my work for the last 15 years or so. And I started with one secretary. Now we are with 40 employees, and we are serving about 500 outpatients, people with severe mental illness, usually a long history of chronic depression, anxiety, trauma, personality disorders, unexplained medical problems, usually a lot of despair. Most are suicidal or have a request for euthanasia. So this is people with very severe, long-lasting problems. And what we thought about 15 years ago is we wanted to make a different approach to psychiatry. We were very much inspired by integrative medicine as a working method, which is now usually called Traditional, Complementary and Integrative Medicine, TCIM. So we used this as a method. We started with this, and then it grew. And besides directing the center, I'm also the head of research, and I did my own PhD on integrative psychiatry in 2014 in Holland at Groningen University. And since then, I've been guiding and directing research, randomized clinical trials on mindfulness meditation, compassion, lifestyle changes such as nutrition, diet, sleep, exercise, and spirituality, and also a randomized clinical trial on yoga for mental health. And especially the part of spirituality is now getting more strong in our country. And I'm also part of a national a group which is writing a national guideline on how to use spirituality in mental health care, which is quite a step for us. And today I'm presenting here mainly in my role as the chair of the Dutch Consortium for Integrative Medicine and Health. We have started it some years ago, and I will explain a little bit about it. But before, let me take you back into history, because it started actually in 1865. That's quite some time ago. In that time, about 150 years ago, there was a man, Thorbecke, who wrote a new law in Holland, which made the first distinction, division between conventional medicine and everything else. So from that day on, we had people practicing conventional medicine taught by the universities, and all the others which were named alternative medicine. This stayed for a long time like this. And then about a little bit more than 20 years ago, there was a new law called the Big Law, which said, okay, now we change. Anyone can practice medicine, but there are specific procedures which you can only do when you have a specific degree, such as operations or drawing blood or any other complex medical procedures. These are only for those who have a degree in that. And since that time, there was more strong approach of TCIM in Holland, but also we have a quite strong opposition. So there are people who really don't like these other medicines, And usually they are called the Union Against Quackery, which is like a union against people who practice bad medicine. That's what they view it. And we have the largest one in the world, although we are one of the smallest countries. So it's quite strong in our country. And we had to put a lot of effort to be able to get to this stage. So inspired by the success of the American consortium, which started in the 90s of the last century and has grown to more than 70 university hospitals, our National Institutes of Health, let's say the governmental agency which divides all the money for innovation and research in healthcare, this governmental agency decided that it should be a commission to see if we could get to a Dutch consortium. They started in 2016, and after some years, a lot of preparation, in 2018, our consortium was founded. I'm the founding president, and we have 6 organizations part of our consortium, which is one university medical hospital, a big one, called the Radboud University. Then we have 3 large teaching hospitals which are non-academic. We have a research institute for nutrition and agriculture. And we have mental health care, which is my hospital where I'm working, and the large hospital, which my Center for Integrative Psychiatry is a small part of. And we decided when we started to make the division into 4 working groups. So all of us together, we have been putting our effort into clinical care, research, education, and policy. These are the main subjects we are working on. And in the last year, we have been also working together with our friends who are now participating in this meeting today, which is, of course, Ricardo Gelman from the Brazilian consortium, and also Françoise Adan and Dale West from the American consortium. There are many people, other people involved, but these are the ones we are together now pioneering. And we are talking with WHO, basically Zhang Qi, who is the chief of the TCIM department of WHO, how we can facilitate the working together of the consortia. And this will be put into some kind of structure of which Zhang Qi thinks a federation would be the best option, so we can learn from each other and exchange. And this is important because some consortia are more active in research, such as the Brazilian. Some are more active in clinical care, such as ours. Some is more from academic consortia, academic hospitals, which is the American. And so we have all our own strengths and weaknesses which can be balanced. So to give you one idea, in the last 3 years, what did we achieve as a consortium, these 6 organizations? We have been counting, and we altogether we have published 57 scientific articles on our research, which is, for instance, about mindfulness meditation. We have some working together of Radboud University and my own hospital on mindfulness for bipolar patients, for instance, but also in many other for many other sicknesses. Then there are 24 research projects active now. A lot is on lifestyle changes, but also on other ones. Also in specifically in pediatric medicine and oncology, we have quite some projects. And then there are 29 initiatives in education, writing like best practices and developing curricula, and 29 projects in clinical care. So this is our harvest of the last 3 years, and now we want to celebrate this event, this moment, as we are now 3 years together. We have all these publications and projects. So we are celebrating this by a national conference, which will be on the 8th of October this year in Amersfoort, in the center of Holland. And then we will be together with a lot of medical specialists and general practitioners, many people who are either already part of the consortium or planning to do so. And then we will talk about how we can move this field further. So I'm really looking forward to that. And besides our own work inside, as I told you, we're working together with Brazil and our friends there and in America and also other parts of the world. So for instance, in Norway, there is NAFCAM, which is a large national institute for research on TCIM. And Mick Young, one of our colleagues and friends, is there now the new director, and we're working with them also. For instance, we did just a paper on COVID and how it led to lifestyle changes for people in Norway, Sweden, and Holland. So many things are happening. I'm very excited about that. I'm really hoping we can join forces and also include other countries from the other 6 regions of the world, which were divided by the WHO, so we can have a global effort coming together to put integrative medicine, TCIM, further. In able to do that, we need to take steps. And in my next talk, which will be, I think, next Friday, the 23rd of July, I will explain a little bit more about what steps we think we need to take in able to get further. So we will tell something about a roadmap to the worldwide integration of medicines. We also talked about this in Macau during a WHO meeting 1.5 years ago. And we've been talking about this also with the Brazilian and American consortium. So we can describe this in a paper. And we call this a white paper, which is like a vision document. It's like a proposal of our consortia, how to move this field forward. And I'm excited about this. I will talk a little bit about it on Friday, and I'm looking forward to meeting all you soon. So I wish you a very fruitful and successful conference, and hoping to see you soon.
We would like to thank Holger and all board of the Dutch Consortium for excellent work in research in the TCIM area. The 3 consortia have been working in collaboration, which has generating great possibilities for the global consolidation of TCIM area. I want to introduce Ricardo Gelman. Dr. Ricardo Gelman is the next speaker. Ricardo Gelman is the president of Brazilian Academic Consortium on Integrative Health. He is member of the Executive Secretary of the Virtual Traditional and Complementary Medicine of Americas. He has a postdoctorate in neuroscience in the area of the chronic pain and anthroposophic medicine. He is a pioneer in the area of integrative pediatrics in Brazil. Welcome, Ricardo.
Thank you very much, Caio, to introduce me. And I'm delighted to follow that interesting panel about network and consortium. I would like to share our experience to build the first consortium in the South America. And as you can see, the importance is the network. Look into the number of countries that engage in that important Second World Summit. The Brazilian Academic Consortium has the logo of that tree that mean in the 5 roots means the 5 regions of the country, and the branches represent the 27 states, and the 29 leaves represent the 29 modalities of traditional complementary integrative medicine included in our national policy. we are 3 directors that work together and engage a lot of researchers, but we 3, me, Caio Portela as the co-chair, and Gyalza Nunes, also director, we work hardly to join that network in Brazil and in international connection. Certainly, the strategy that everybody knows from WHO stress the importance of study the safety, efficacy, and quality of the products to strengthen the regulation. Then the research, it's fundamental to foster all that fields. Looking into the concept that put the whole person in the center, beside the proposal to be informed by evidence, that it's very important also, but just that point to focus the whole person in the center instead of the disease, for me, it's like a so huge paradigmatic change. That means like the change from geocentric to heliocentric view of the universe, because really it's completely different if you look the patient as a whole in the center. Looking to the models of medicine integrative health, we realize that each country has his own perception. Looking to the NCCIH focus, they're focusing 2 big topics: the natural products and the body and mind practice. Looking more to the Brazilian and perhaps the European model, beside that 2 areas, we emphasize very much the whole medical systems that has his own character. And since the 15 years ago, in 2006, we was introducing in our national policy several modalities, indeed 29, but looking to them, we can compare that some are from whole medical system or medical rationalities, as you call here in Brazil. The natural products that have regulation from our drug and we name Anvisa, it's like FDA. And the non-pharmacological therapies, it's a big field that includes one that's made in Brazil, completely Brazilian, that's integrative community therapy, as Mariana Cabral mentioned today. In a survey done recently, last year, looking to the implementation in Brazil, you can see that basically the implementation are in the primary care, engaging more 30,000 teams, more than 10,000 health units that has at least one modality offered freely, more than 4,000 Brazilian municipalities that represent 77% of the total cities in the country and in the whole capitals. But basically, it's in primary care. In hospitals, it's not our model. It's only less than 4%. And this paper from Eric Bass and Harold Ramaher, it's very interesting because compare, as Nadine just presented today, the comparison between whole medical system and conventional biomedical model. And if you look to this, it's very important to emphasize the model of care, comparing the biomedicine, like looking to the human being like a machine, and from the whole medical system as an organism that engage the biopsycho and spiritual dimensions. And then there are several whole medical systems to be compared and to be adapted to each country. looking also to the connection, how to implement that model. There are some ideas. These come from a partnership with Germany that also in a hospital looked like this. What's interesting to think in the dimensions, the physical structural dimension, that it's more achieved by surgery, synthetic drugs, the allopathy. It's completely different from the vitality dimension that are rich from physical activities, yoga, acupuncture, tai chi, external therapy. We just did now the yoga in the active pause. We feel our vitality changing. Also the natural products in general and aromatherapy and all that field. And the emotional dimension include arts, dance, music, psychotherapy, floral therapy, and also aromatherapy. And the spiritual dimension can be care or treat with meditation, biographic counseling, clinical empathy, resilience, and the internationality. That's one key aspect with spiritual exercise. That group from Netherlands that studied the connection with the whole medical system and the markers in the genetic level and metabolomic level are very interesting, because you can see the future of the medicine and the field of health, because everybody is searching the same thing: how to individualize the patient, how can you use the ancient and modern medicine to be in connection. And the new discoveries in our field of TCIM are really remarkable, like the gut-brain axis, looking at depression, for instance. It's more abdominal problem than the head problem, as you previously think about how the microbiome nowadays it's named psychobiome, and also the effect of the meditation that started with the huge work of Kabat-Zinn with mindfulness, but nowadays there is so many research showing the improvement of immunity and the anti-aging effect, even in 5 days. We have in Brazil a center connected with the Einstein Hospital that study in 5 days program of Zen Buddhists that can achieve the same effect that for several days of daily meditation. Then in one Congress in Brazil in 2017, we had that question: could we start together the researchers? This is the founding group in 2017. Was hot, as you can see. It was in Natal. And this group of 19 researchers from 20 universities had the idea to create the consortium. And 9 months later, together with the virtual health library of TCIM of America, was launched together, the Brazilian Academic Consortium, in a big congress with 4,000 people presentially in Rio de Janeiro. The main tool of our website, it's Miro, an important work from Virtual Health Library of TCIM, where Veronica presented in the first moment of the Congress today. That's the database that now include more 1,500,000 publications than we can search. And the other thing was important for us, it's the connection with the Pan American Health Organization. Then we signed in 2019 formal cooperation with PAHO. And also to be connected worldwide, we now are one of the chapter of the ISCMR that was presented today as an international multidisciplinary scientific organization, beside together with Canada, China, Iran, and South Korea. we gathered the researchers through the thematic committees. Then the first 4 were in the field of pain, natural products, integrative pediatrics, integrative oncology. But nowadays we have more in mental health, Ayurveda, nature and health, and the next will be about methodology. From the pediatric committee, we organized in 2019 important congress. At several groups here belong to the come attend for this congress, because we gather 11 countries and we developed together that São Paulo Agreement on Integrative Pediatrics, a consensus-based document for integrative health on children. And now we're very connected with the Swiss group and the US and Israel and other groups that come from our pioneers experience in the São Paulo University, where I was the leader the last 5 years. Then looking to that website of the Virtual Health Library of TCIM, I did a quick search to this presentation, put in the name Traditional Medicine, and you can achieve more than 20,000 publications. But if you put the name Complementary and Alternative Medicine, it's interesting, that's lower, the number, 22,000 publication. And if you put the Integrative Medicine, you can find in the PubMed only 5,000 publication, because that website are basically connected with that PubMed. Then that goal from WHO to standard the terminology, I think it's a key point for our Congress, because each country name it indifferently. Even in the US, as mentioned today from Ryan Bradley, the formal name of the National Center was Complementary Alternative Medicine, and changed to Complementary and Integrative Health, as we did in our Brazilian consortium. Salud Integrativa in Spanish, and Integrative Health. We did a small survey in 2019 to look the profile and the number of researchers in our country, and we gathered more than 500 researchers, and also another center that connected with Oswaldo Cruz Foundation, an old foundation, it's Observa PIX, did also a survey of numbers of groups that are affiliated to the government as a working group or research groups. One of the main field of research that we recognize, it's in study of medicinal plants. Looking to Brazil, have several biomes that are completely different medicinal plants, and especially in Amazon rainforest, it accounts for about 10% of no species found in the world. And it's very important that the Amazon area involves 8 countries besides Brazil, but also Bolivia, Peru, Ecuador, Colombia, French Guiana, Suriname, and Venezuela. Then to study and connect the plants, you don't have barriers. You have natural regions that need to be cared. And I'd like to emphasize that study of Uncaria tomentosa and Guaraná, that it's very useful to fatigue-related cancer symptoms that were studied very well in the last years in Brazil. And also the effect of passiflora, not only as antioxidant, but also with apoptotic potential to cancer patients. In the acupuncture, it's certainly the biggest field of research in Brazil. Looking to the bibliometric analysis, Brazil, it's now in the 7th country in the world that more publish acupuncture specific papers, And looking from 2011, where Latin America represents only 6% of the all publication in TCIM, nowadays Brazil belongs to the group of top 20 countries that publish in TCIM journals, beside India, Taiwan, and a little bit more than Germany. But the first, it's China, US, and South Korea. From a request of the Minister of Health in 2019 to foster the TCIM based on evidence, we had an important meeting together with Virtual Health Library representative, that's Veronica Vidala, and also the head of the National Cancer Institute in Brazil, and several other important people that are discussing with the government. And then was decided to follow the method of International Institute for Impact Evaluation, the 3IEA. And through this, we engage more than 50 researchers around the country, and we did the workshop and nowadays the Mariana Cabral is the leader of the methods group, and Veronica, me, and Caio, we four were the leaders of that group that follow. I'd like to share quickly, because I don't have too much time, but several maps are already available, it can be translated to several languages. And in the first block, we analyzed almost 900 systematic reviews of meditation, acupuncture, Chinese body practice, yoga, medicinal plants as the top 5. And the main outcomes we discover are to mental health, and second to pain and hypertension, diabetes. And the effect are mainly positive effect, or in direction of if potential to positive effect. That's almost none with negative effect. In the field of cancer, we realized the importance of Chinese medicine together with meditation, medicinal plants, and to pediatric oncology Chantala, that have interesting systematic reviews. And specifically the breast cancer that have the main number of publication from the general literature, and also to pain and fatigue, nausea, and toxicity from chemotherapy. And these fields that are emphasized here create the second block, were almost done. And now we can say that we have not only almost 900, but we have more than 1,500 systematic review that can be shared in the next month, engaging all this field of integrative medicine. And to promote the access in a easier language, more feasible to understand, we developed together with Minister of Health and the Fiocruz, the foundation, a knowledge translation program, and each 2 weeks we publish specific paper more accessible to the manager in public health and health professions. The COVID was an important partnership with our TCIM America Network, and I can say that just that the first map we published already, but the second we're doing now, and I can have time to share, but just to we update that have about 58 studies, 44 reviews to allow us to create a guideline to COVID-19. And with the Ministry of Ayush, we developed that partnership with the guidelines to COVID-19 of Ayurveda. And in partnership with the Technion University in Israel, we developed a translation of the subtitles of that wonderful course about traditional herbal medicine in supportive care, cancer care. And we are together with the group of Germany and Italy in that quadrangular project of translation. Then it's accessible in Portuguese, and we hope that soon we can do in Spanish in cooperation with the Virtual Health Library. And just to conclude, this is a new project that's very important also. It's how to collect the data in real life words. How the practice can be gathered in the research model, and together with the Fiocruz, we're doing the partnership in developing that community and sharing the experience. That is a kind of model of shared experience, inviting people from the whole country to share. And just to conclude, the last slide, it's in the same direction of Roger from Netherlands. Since our first technical cooperation meeting in 2018, now what we want is to invite other institutions of research to join us in the idea of Zhang Qi for WHO to create a federation of academic consortia and TCIM research institutions to promote the collaborative work. Thank you very much. And just to mention, we are organizing together with the TCIM American Network and the Brazilian Academic Consortium our next Congress that will be in Manaus. It will be hybrid, presential and online, 4 to 7 April next year. I hope that you could attend and you can have dialogue between the two areas, the medicinal plant and the TCM. Thank you very much.
Thank you, Ricardo. I want to introduce the next speaker, Dra. Natália Sofia Aldana. Natalia is the editor-in-chief of the Virtual Health Library of TC America's Network. Natalia, it's a pleasure to be here with you.
Yes, I'm here. I just was checking my mic. I am thinking about the language. Pero creo que voy a hacer la presentación en
I think I'll do my presentation in Spanish. For the audience or the Spanish speakers, can change the tone of voice that they're listening to, so we can switch it up a little bit. And I believe that in Rotator, they were asking me to speak in Spanish, so I'll start sharing my slides in a bit. Just 1 second, please. Let me look for the share screen. I think that by having my YouTubes open, it's causing a little bit of difficulties with my screen sharing. Now you can see, right? Perfect. So I'm going to make a presentation in Spanish, like I said, but the slides are in English for everyone to read it and make it easier for people. Well, I wanted to talk to you about the current health library, the virtual health library model. We have all these models. I don't know if you can see my screen. Yes. There's a chart here that I want to show you. All right. I think it's fine now. So I wanted to tell you, because this is an example of a network collaboration to favor the research space in traditional medicine and complementary and integrative. So we've heard really nice experiences from the collectives such as the Netherlands Consortium and the Brazilian Consortium. And I think that overall, many people in the TCI feel at some point we've faced these challenges that research in MTCI has, but not just research, but as such, but to articulate also and to implement the traditional medicine, complementary, and these services of health. For us as a collective, one of the strategies where we feel that we can obtain or achieve that articulation and to make it even better in the systems of health, so we can add all of the patients, we can reach all of the patients so their attention can be covered by their own traditional systems or by their own traditional systems of health of their country. In the it's important to have this into account to look for the best decision in clinical terms, but also in political terms. All right. So this virtual library of your health will follow a model created by Pireme 22 years ago. This is a model of network collaboration to enable access to health information. This is a working model which is collaborative with different institutions. We have over 135 virtual libraries. Ours it's one regional and a specific library in the MTCI area. We gave this space as a collaborative space and we've developed it in the traditional network of complementary natural medicine. So what are our goals? Just like you provide visibility, access, usage, and to generate scientific content, academic and educational, that could help contribute to the promotion, to the development, and to the integration of traditional medicine, complementary and integrational in the health services. And how can we achieve that? If we promote access to this scientific information, it'll be easier for a politician to make a decision to enable the legislation and to include this type of regulation in practice of products and of practitioners, but also by facilitating the access to this scientific information, it will make it easier for medical clinics to make decisions for the body of the medical staff of health professionals can see that there's evidence and that can probably need their patient to be submitted to a different colleague and try and understand that a health situation of a patient can be worked the different levels with different colleagues, and that's going to facilitate the recovery process of a patient, but also inform decisions at the level of the patient itself, not just for health professionals of the biomedic model, but for all of the professionals of health in the MTCI area and for the people that are the knowers or the libraries of the ethical groups. And we have the objective of make this exchange easier. When we're doing this summit is to comply with one of the fundamental roles of the library, which is the enabled exchange and collaboration among different actors, enabling visibility of the good practices. The network was created in Nicaragua in a meeting that happened in June 2017 that was summoned by the OPS or WHO organization and different stakeholders, and it was to talk about what precisely the traditional and complementary medicine input. And that was really interesting because we were looking at the different people from different universities and research bodies and indigenous communities. So we had the same mindset and we decided to organize this network and to organize a network that has as a main goal to develop a whole a common agenda that can enable the advance, or it can aid us to make it more efficient and faster to have this integration of MTCIs in the health systems. We know that they exist, and we had a wonderful day yesterday talking about that from different regions, but we know that according to the national context, in some countries, that legislation of recovery and that integration has taken some time. So the network as such has a common goal of enabling this and facilitating also the strengthening spaces of the research capacities. So the network itself is responsible for the BBS and its a network by itself. So it has altogether universities, research groups, that has a pre-grade, post-grade, and we have universities of traditional medicine and complementary medicine and integration of the Ministry of Health of the region. We have universities that train professionals. We have foundations that have research and work in this area, and also indigenous organizations. And through that collaboration in networks, we manage knowledge, we promote information, systematize information, we translate the knowledge, we enable the access to information for decision makers, and also we enable and facilitate, and that's what we want to facilitate, the strengthening spaces for research and for development in investigation and research, and that's to contribute to the well-being of population, of individuals, of communities, and to contribute to the development of health systems that are more inclusive, that are more sustainable, and at the end, that will contribute to obtaining universal health. So this network, and many of us here are a part of this network, those visible and those that are behind the scenes. Precisely, this is a network made of networks. The consortium is a part, also the biomedic school is a part. Many of the universities that are you're looking at during this weekend and you'll look at next weekend are also a part of the network. I need to see here in these logos, there's some others to be included. We have 17 countries at the moment: Argentina, Brazil, Bolivia, Chile, Colombia, Cuba, Costa Rica, Ecuador, USA, Guatemala, Mexico, Nicaragua, Paraguay, Peru, Venezuela, and Haiti. And as I was saying, given that we are network made out of networks in each and one of the countries, we have different types of, of stakeholders and differently. And anyways, we get together for to basically look at the libraries projects, and this project was launched in March 2018 from the director of the WHO and the IDN director, and these are part of the teamwork. These are the colleagues and colleagues that started this. This is our project, and this is a platform to put into evidence a piece of work that we're doing. You'll find here that we have this available in Spanish, Portuguese, English, and we have a whole session to be make to make that we made in this library. We thought that a library shouldn't be limited to have only books. It's important to have articles, of course, but it turns out that precisely one of the difficulties that we have is, particularly in Latin America, is that not all of the academic scientific production is reaching the journals. I was telling you that in the previous lecture, only 15% of it is published in scientific magazines. That means that a lot of the academic production that's conducted in the region is not visible. And if we talk about even work in the indigenous communities that have their own ways of researching, maybe they see that the field is not used to it, but they have their own ways and paths, and they have their own methods of working. It's true also that from this academic scope, we make these collaboration agreements, and in some situations, there's a decision of knowledge making, but there's a lot of knowledge to be obtained out there that's developed and that's being researched, especially for traditional medicines in the region, facing different regions, complementary medicine, therapeutical methodology, and non-inclusive. So this library, you'll be able to see that the database is right there. You have a search box and you'll find a collection of over 5,000 documents that go from index magazines, but also different databases. And also, right now we're in the process of following up with universities to have access to these virtual repositories to look for publishings and pieces of work. And we are in the process of working with indigenous organizations to register the production of communities. And also, we think that we thought that we need not just documents, but we need to look for a way and for all of us to have access to that. And that's why the library, it's almost a space. And I'm going to dare to say this word of mapping of what's going on with MTCIs in the Americas, and it will allow us to visualize and to be able to see what's going on in the region. So we have a whole section of institutions and a directory, and I'm going to go through this really fast because you'll be able to go to the web page. In the YouTube chat, we'll leave you the link. We have our database here. And of course, out of all of the database that we work with, we connect information. We have our own database, which Mosaic covers information that's produced in ministries of health, in the ministries of health, at the OPS office or the WHO offices, to work with communities, degrees, thesis of all any of the working systems that are included and that I've mentioned, and also in magazines that are not annexed but have been reviewed from by peers. So in this page, you also find information about, and let me go back a tiny bit just for a second because I think it will be easier to show it here. In the main menu, we'll see a whole directory of what are the institutions in the region that work in the MTCI, being in research and education. And you'll find in the other tab the policies and regulations of each one of the countries that from the ministries were able to facilitate some information. You'll see a whole section looking at what are the MTCIs, and that's where you can find these evidence maps in that main menu information about the educational agreements, and we're generating information about different regions. There's a whole specific region to talk about the tools to strengthen health from the regional systems in the different MTCIs. There's a specific region, a specific area for traditional medicine of ethnical groups, a whole section that's called strengthening research that has the goal of precisely improving the research capacity that we have in the region, and another section that's dedicated to articulation in health systems. We have a new section, events, and I'll stop here to let you know that within the framework of the pandemic and taking advantage of the nice work that the financial or the academic consortium has made, even though I'm running out of time, the work that was developed by with the IDREM support, which is the Latin American Center and Caribbean of the Sciences and of the Pan American Health Organization, and we have established the development of these evidence maps that Mariana was telling us about. That's available through the virtual library, and recently in different collaborators from the network that are not from Brazil have started to support to the development of this research. We have a whole evidence map dedicated to contributions of MTCIs for the pandemic, and we have also a whole library of knowledge. And what we look is to translate knowledge to make it easier to build summaries, organizing information so you can find it. Like, for example, nutrition, how can it strengthen health in pandemic times, how the MTCIs can help me in my own mental health, in my occupational health, in my stress management, into strengthening that immune system. So this is a project that is a whole product of the collaborative type of work of the MTCI Americas Network, with their all volunteers. And this is a really nice piece of work because it's facilitating that information to all the populations and evidently to health professionals. We've made last year an international symposium in togetherness with the consortium, with the Medical School of Peru. And this year we are working as a collective, really nice collective, developing an evidence map of traditional medicine, complementary and integrational in sustainable health. And and a whole window of knowledge facing ancestry medicine in the Americas, and we're doing different types of events, webinars that can be also be found in this channel, and we'll carry on with the process of expanding with different countries of the region, with the institutions that have experience in public health, and we have a lot of countries, more than 173 countries, a lot of users. And I just wanted to thank all of the collective of a lot of people of many countries of the region of the Americas that made possible this whole piece of work during these 4 years. So thank you very much to all of you.
Just gracias, Natalia,
Thank you very much,
for this
Natalia.
wonderful work with TCIM Network and Virtual Health Library. I want to introduce your next speak, Dale West. Dale West is the Executive Director of Academic Consortium for Integrative Medicine and Health in US. Dale has more than 20 years of experience work with nonprofit organization with expertise in strategy development and the implementation, operational excellence, healthcare education, international development, and fundraising. Dale, it's an honor to be here with you.
Hi, everyone. My name is Dale West. I'm the Executive Director for the Academic Consortium for Integrative Medicine and Health. And I am thrilled to be here with you today. And I want to thank the organizers for allowing us a few minutes to give you an update on our activities. We are the organizational home for 76 prestigious academic medical centers, health systems, nursing schools, and osteopathic colleges, working together in a shared commitment to integrative medicine and health through research, education, and clinical practice. Our mission is to advance the principles of integrative health within academic institutions, and we do this through supporting and mentoring academic leaders, faculty, staff, trainees in education, research, and clinical care. We also do this by disseminating information on rigorous scientific research, educational curricula in integrative health, and sustainable care models. And we do all of this in many ways to influence healthcare policy. You see our core values at the bottom: evidence-based and informed, community building, transformational change, leadership, integrity, and interprofessionalism. All of those things are critical to changing the current landscape of healthcare around the world. We have 76 member institutions in Brazil, Australia, Canada, Mexico, and the United States. We have just recently been able to add institutional members outside of North America because of a technology platform, which I'll talk about in a few moments, because it allows us to bring people together in a way that we could not before. But we are excited about that. We are excited about being able to expand the reach of the organization outside of North America. Our membership are institutions, and then within those institutions, all faculty, staff, students, and trainees get complimentary membership within the consortium. Our membership institutions are academic medical centers, health systems, osteopathic colleges, and nursing schools, with the osteopathic colleges and nursing schools being new within the last year. We have an incredibly dedicated board of directors. There are 9 directors, which you can see here. They put in countless hours, not only within their own institutions to advance integrative health and medicine, but also within the field and within the organization. And I couldn't be more proud to work with them on a daily basis. I want to talk a little bit about the strategic priorities for the organization that our board of directors has set. The first is comprehensive pain care. The The second is engaging conventional medicine. And the third is building community. For comprehensive pain care, we are updating and disseminating non-pharmacologic pain management resources. Our pain task force is currently updating the evidence base and policy implications from our 2018 comprehensive pain care white paper. The first paper on acute care should be available within the next few months, and we will ensure that it's open access so that everyone has access to the research article. This is coming at a critical time, at least here in the United States, where most states are reporting that opioid death and overdose have increased greatly during the pandemic, which is incredibly concerning. The second strategic objective is engaging conventional medicine. I'm sure many of you are facing the same things we are, where conventional medicine is skeptical of the practices within integrative medicine. So we are working with the Samueli Foundation to develop educational materials for conventional providers to ensure that they understand the latest evidence on the safety and efficacy of integrative medicine modalities. We're also updating the competencies for medical students within the United States to ensure that the education that's being provided to the medical students is consistent with this evidence. Just as one example, nutrition is not mandated for medical schools here in the United States. That has to change, and we're working on doing that. And the third is building community, and this is a strategic priority that will always be on our strategic priority list. Our main drivers for community building is increasing the diversity of our own leadership within our volunteer levels, supporting the growth of our special interest groups, which I'll talk about in just a moment, hosting high quality meetings and educational opportunities that foster community within the field, and increase institutional collaboration, not just with our member institutions, but throughout the world. That is going to be something that is going to be incredibly important for all of us to do. I mentioned special interest groups. We have 17 special interest groups that cover a variety of topics. We started these last April. They have grown tremendously. In fact, over the last 3 months, they have almost doubled in size. We are adding new special interest groups regularly as our members become interested in adding new topics for small group discussion. And we're able to connect the membership and the special interest groups on our new platform called Consortium Connect. This is a new online platform that we rolled out last April of 2020. It has allowed us and allowed our members to communicate and share practices and resources with one another, even through the pandemic. It has been incredibly important, more important than we even thought when we released this. And as I mentioned earlier, this is the platform that has allowed us to expand our membership outside of North America, because people can communicate with one another and engage with one another regardless of time zones. We have a number of high quality educational events and resources. We host the biennial Integrative Congress for Integrative Medicine and Health. I'll talk more about that in just a moment. We host an annual members meeting where all of our members gather and share ideas and best practices on clinical research and educational opportunities. We started this year hosting a biennial Integrative Medicine and Health Symposium on years opposite of the International Congress. We provide free monthly grand round webinars that talk about important topics and offer free continuing education. And we also have an online event calendar. And so if you are planning on hosting an event and would like to get information out to our members, please send us information on your event, and we would be more than happy to include that within our online calendar. I mentioned the International Congress. We'll be hosting the next International Congress May 23rd through the 26th next year, 2020, in Phoenix, Arizona. We are currently accepting abstracts and session submissions. That actually just opened on Monday. We will be accepting those submissions through October 29th. So we hope that you will consider submitting an abstract or session submission for the Congress. There will be more than 1,000 people attending this meeting, and it really is a great opportunity to collaborate and work with one another. I want to talk a little bit about the support that we provide to students and trainees, because this is a special focus for us. We provide travel funds for students and trainees who are presenting at our conferences. This is something that we're incredibly proud of. We were able to, for the symposium that we did in April, we were able to fund every student and trainee who were presenting. At the Congress next year, we will be able to provide a number of travel grants because we have generous donors who are providing grants to us. During the Congress, we provide several times in which the trainees and students can get together. One of those times is our Emerging Leaders Lunch. It's where they are able to come and meet and have lunch and discuss topics with some of the top professionals within the field here at the Academic Consortium. We also have a number of volunteer positions that allow the students and trainees to get leadership development and to really engage with the field that they have chosen. We also have a program called LEAPS, which is Leadership and Education for Students in Integrative Medicine. And that is a one-week immersion course that happens that really gives medical students and students in healthcare and other students in healthcare fields to be able to come together and truly understand and have an immersive experience in integrative medicine. That next program will be in June of 2022. You can find more information on our website about that. And so if you have students and trainees that are interested, please let them know. We would love to have more international involvement within that program. If you're looking for a way to publish your work, or if you're just interested in the latest advances in integrative health, Global Advances in Health and Medicine can help. Global Advances is our peer-reviewed online access, open access journal. We publish it continuously throughout the year. It is free to be able to access any of the articles that you might like to see. And so you can find more information on our website. And we also encourage you to sign up to receive notifications when we have new articles, which is almost every week. And I would be remiss if I did not thank the many, many volunteers who put in countless hours to make sure that all of the things that we're doing are happening. These are just a few of the volunteers that we have. I am thrilled to work with such a dedicated group of people who inspire me every day. And so I want to thank them and really appreciate all of the time and work that they are putting into making sure that our vision of integrative medicine and health for all is realized. Here's our website, www.imconsortium.org. Please visit that at any time for more information. There's information there, contact information from me, the executive director. Feel free to reach out to me if you have questions or ways in which you'd like to think about collaborating. Dr. Francois Adan, who is our board chair, is also listed there. You can see her email, and she would be thrilled to receive a message from you as well. So again, thank you to the organizers of this conference for allowing us a few minutes to talk about the academic consortium based in the United States. And we look forward to hearing from you.
Thank you. I want to introduce your last speak, Doutora Tabata Parker, que is Executive Director of Academic of Integrative Health and Medicine. She was named Physician of the Year in 2015 by American Association of Naturopathic Physicians, and the Visionary of the Year of UTME Reader in 2011. Tabata was founding and co-chair of the Master in the Global Health at National University of Natural Medicine. Tabata, it's an honor to be here with you.
Thank you so much for having the Academy and for having me and inviting me to speak. It's really just such a pleasure to be here and to be working with all of you. I'm going to share my screen real quick here. Can you see that all right?
Yes, perfect.
Okay, great. There's a huge storm starting and thundering and lightning, so I hope you guys can hear me okay. So today I'm going to speak about building a global movement in integrative health and medicine, a history of networks, collaborations, and the formalization of integrative health in the United States and North America. So the Academy of Integrative Health and Medicine is an organization that has been built on collaboration and really began in the 70s. The mission of our organization is to advance holistic and integrative health globally. We're dedicated to engaging a global community of health professionals, health seekers in innovative education, leadership, interprofessional collaboration, research, and advocacy that embraces all global healing traditions to promote the creation of health and the delivery of evidence-informed, comprehensive, affordable, sustainable, person-centered care towards universal health care and holistic health for all. We have an incredible board of directors, an interprofessional board, and that really is one of our values. And I'll talk a little bit about that, about how we truly broke down the silos that existed in the United States, even within integrative health. So we have our founding president, Dr. Mimi Guarneri, who will be speaking later next week in this Congress. Our current board chair, Dr. Bill Meeker, who is a chiropractic doctor. Lucian Thornton is our past board chair. She's the immediate past board chair, and she is a holistic nurse. Brad Jacobs is an integrative MD and the treasurer and another past chair of the board. Scarlett Soriano is a medical doctor. Rachel Abrams, also an integrative medical doctor. Jean Davis Hatcher is a PhD chiropractor and a physician's assistant. Mike Hogan and Stefan Knobs, who is a healing touch practitioner. So a little bit about our history. Our history is actually the coming together of multiple groups in the United States. The American Holistic Medical Association was the oldest holistic association for MDs in the United States, and it began in 1978. And the AHMA was really a body of clinicians that were dedicated to holistic medicine, which was, the term used back in the 70s. The American Board of Integrative Holistic Medicine also merged to become AIHM in 2014. And the American Board of Integrative Holistic Medicine was the first board in the United States that began to train clinicians in integrative medicine. And finally, the Academic Collaborative of Integrative Health, also known as the Collaborative, recently merged with us. And so these organizations, the AHMA started in 1978, the ABIHM in 1996, and the Academic Collaborative for Integrative Health in 2008. So we really are a movement of clinicians, educators, and collaboratives. Our timeline from 1978 to 2021 really shows the breadth of our work, over 43 years since our inception, and collectively over 75 years that each of the different organizations have been working. So in 2014, integrative medicine became a formal national specialization in the United States for medical doctors. Formal MD specialty recognition was accomplished in 2014 when Dr. Andrew Weil, Dr. Mimi Guarneri, Dr. Tierra Lodog, and other leaders from around the country came together to form the American Board of Integrative Medicine with the nationally recognized American Board of Physician Specialties. So the ABPS is currently where the American Board of Integrative Medicine lives. That year, ABPS launched the ABOIM National Specialty Certification in Integrative Medicine for MDs and DOs in the United States. This was the logical next step in the professional evolution of MDs here in the United States that had already certified thousands of integrative medicine physicians through one of our founding organizations, ABIHM. ABPS is a nonprofit umbrella organization of more than 16 medical specialty boards that certifies and recertifies physicians, MDs and DOs in over 16 specialties in the United States and Canada. They are one of 3 national organizations that oversee the Doctor of Medicine and Doctor of Osteopathic Medicine certification in the United States. So with that success, our leadership came together and really sunset the ABIHM certification. But in that process, we decided that we really wanted to bring together all of the different professions in the United States. This board certification occurred at the same time that we decided to solve another issue within our professions, that of the division between medical doctors and other integrative health professionals. For years, many believed that interprofessional training and collaboration was key to the success of the integrative health and medicine movement. The belief that ultimately united us, that divided we stand, or we stand if we are united, and divided if we will fail. So the Academic Collaborative for Integrative Health, our network now that includes over 40 national integrative health and medicine organizations, universities, and associations, really, again, was an incredible collaborative effort that started in the early 2000s that brought together all of the national academic organizations associated with the 5 licensed integrative health and medicine professions that have a federally recognized accrediting agency in the United States. So who are we talking about? These core licensed integrative health disciplines in the United States. So in order to be recognized at this level, you must have a federally recognized accrediting agency and licensing. Those 5 professions include acupuncture and oriental medicine, which have about 28,000 practitioners, chiropractors that have about 72,000 licensed chiropractors, direct entry midwives, about 1,300, massage therapists, so licensed massage therapists, 250,000, and naturopathic doctors, about 7,500. So the core body of the ACIH Council are the accrediting agencies, the certification and testing organizations, and the councils of colleges of the 5 licensed professions in the United States that are specifically integrative health professions. We also
Okay.
Tabata? Hello, Tabata. Can you hear me? I believe we have technical problems with Tabata. Just a minute, please, for our technical team.
Caio and Tabata is with a loss of signal because storm in Nicaragua. She's trying to come back.
Thank you, Natalia. I would like it to thank John for being with us. If you're his birthday,
It's
John
my
is
pleasure.
the next.
Thank you.
John is the next speaker here. Hi, John.
Hello. Thank you. Can you hear me okay?
Yes, John. We have finishing this panel, and you.
Sure, it's fine. I'm in no rush at this end, so don't worry. No pressure.
Yes, thank you.
Hopefully, we can get Tabitha back.
Yes. Without energy in the place.
Caio, nosotros colocamos a tela de espera enquanto está essa dificuldade técnica para a gente conseguir resolver o. Hello, everyone. We have some problems with Tabata connections. We are in the questions here now. We have one question for I believe that's for Ricardo.
The question is, do you have the link for the translation for the traditional about medicine in Portuguese?
Hello.
Hi. I can answer this question. Depend of your interest. We have a Brazilian pharmacopoeia of medicinal plants that includes several native plants. Then it's an important document, and they will also have the list of the named Renami, that it's the name of more than 71 medicinal plants used in the public health system, and some of them are native plants. Then if you could contact me directly, I can send you the link of the documents, but there are several groups, of course, you can this. But it's interesting to mention that there is a disparity between the number of medicinal plants in the region and the number of plants available in public health. That's so few. But even though we can share the lists. Thank you.
Thank you, Ricardo. I believe Tabata is come back with us. Tabata, are you here?
I am. Thank you so much. I'm going to share my screen again.
Go on.
My apologies. So thank you all, and sorry about that interruption. So I was speaking about the licensed integrative health professions in the United States, and those core licenses include acupuncture and oriental medicine, chiropractors, direct entry midwives, massage therapists, and naturopathic doctors. So the Council of Colleges, the accrediting agencies, and the certification and testing organizations of those 5 licensed organizations are the core members of the ACIH Council. But in addition to those members, many of the numerous universities representing the 5 integrative health professions, as well as other traditional world medicines and emerging professions in the United States, are also a part of the council. So I just thought it would be interesting to take a look at the progress, the expansion, maturation, and recognition of both the licensed integrative health professions in the United States, as well as the formalization of board certified level integrative medicine doctors, MDs, and DOs in the United States, so that you can see, the accrediting agencies and the national exams. The chiropractors really led that within the United States with the first formal profession to have a national exam that was created in 1963. They received formal U.S. Department of Education recognition, which really allows the universities to be recognized at a national level in 1974. And their accrediting agency was established in 1971. And so you can compare each of these licensed professions to just kind of see what the trajectory has been over the last 40 and 50 years. At the same time, if you look at the MDs and DOs, MDs and DOs started formally training in integrative and holistic practices and principles in 1996. The ABIHM, which was our AIHM's predecessor organization, trained about 7,000 doctors, and those doctors use the ABIHM connotation after their name. MDs and DOs then started getting formal recognition through the National Fellowship process in 2014. That process now requires a 2-year fellowship in medicine for MDs and DOs to sit for that exam. And there are about 1,000 MDs and DOs who have gone formally through that process. So one other thing that is a bit different than in other countries is that education and licensure in the United States, the professional licensure and scope of practice for healthcare providers in the United States is at a state level, not a national level. So in each of the 50 states, every state has different laws that mandate every type of healthcare professional. While conventional professions like medical doctors and nurses often have similar scopes of practice across states, integrative health professions like chiropractors, naturopathic doctors, and acupuncturists, for example, may have different scopes of practice depending on the state law of the state that they're practicing in. So that is a very different type of model. There are many licensed and accredited professions in the United States, and this is just a resource for all of you to see those different accreditation bodies, board exams, colleges, council of colleges and associations that are the nationally recognized bodies for each of the major health professions in the United States. And, this is a very small slide, but the takeaway here is that, again, in the United States, the majority of health professions begin studying health or medicine after they complete a 4-year undergrad bachelor degree in a university. And then they receive anywhere from a 4 to a 7-year doctorate degree, with the majority of professions having a 4-year specific program where you're studying chiropractic medicine or conventional medicine or naturopathic medicine, osteopathic, et cetera. So this is just a great chart to kind of see what the differences are and what the similarities are around different professions, which ones have residency and which ones have board exams. One of the things that we are dedicated to at the Academy is interprofessional education and the value of that. And the Institute of Medicine in the United States report examined ways to measure the impact of IPE on collaborative practices and health and systems outcomes in 2015. And so we know that when we come together to learn, we really provide better care in healthcare models. One of the things that we did when we created the AIHM Fellowship in 2016, we launched the first ABOIM approved interprofessional fellowship in integrative health and medicine that really was interprofessional in scope. And our fellowship director will be presenting about the program later in the week. But the thing that is most unique about our program is that it is really designed for all clinicians who really want to learn this, who have completed postgraduate education. And so we are really the only fellowship that includes both the integrative health professions as well as medical doctors, osteopathic doctors, and other conventional providers. And it truly has been one of the most successful and incredible programs to see how people learn together. In all of our 50 courses, the AIHM Fellowship course outlines were developed using the competencies of the academic collaborative of integrative health, along with the ACGME domains, which is the main body of accreditation for medical curriculum in the United States. So the Academy also has global chapters and student alliances that are bringing people together locally as a part of a diverse global community, working collaboratively to shape the future of healthcare in order to serve the whole person, body, mind, spirit, and beyond, to include community and planet. Our goal is to synergize and amplify a global community of interprofessional collaboration of individual clinicians, providers in TCIM, organizational members, agencies, industries, sponsors, researchers, all of us coming together to strengthen what we do. And like many have presented here, the MCCI, RED, the Network of the Americas, CABSIN, the Virtual Health Library, all of these amazing organizations, we are finally coming together in ways that will truly help us move forward globally. So these are just some of our chapters, really from all over the world now. And together we are explicitly committing to build an inclusive model of integrative health globally, dedicated to equity and holistic principles. Our strategic priorities are interprofessional education, evidence-informed and evidence-based integrative health, membership empowerment through special interest groups, and building a global network and community. We invite you to our next event. The AIHM People Planet Purpose Conference is actually back in person. So this October 29th to 31st, transforming consciousness and creating global unity in integrative health and medicine is our theme this year. It will be a hybrid event, both in San Diego, California, as well as virtually. This is really where we bring together leaders from all over to present cutting-edge evidence-based clinical talks, inspiring keynotes, interactive daily roundtables, and collaborative community. So I just really want to thank you all, and I'm so deeply moved and excited about the direction that we can move together globally to really provide holistic, integrative, traditional, and complementary care through universal health systems everywhere. Thank you so much for your time today.
Thank you, Tabata. I want to express my admiration for Natalia and Tabata, who do such important work in the area of TCIM, and who were essential for the realization of this event. I believe that the collaboration between all these institutions, three consortium, Virtual Health Library, and TCIM Network, and IHM are very important for the growth of the TCIM area globally. And
Kyle, I'd also like to just say that it has been truly an honor to work with every one of you. And I just want to thank Dr. Martha for really having such this vision that brought us all together in a way.
And thank you
like
again.
this.
And now you... I don't see.
Sorry, I did want to call out Natalia because for those of you who know Natalia, she is just one of the most incredible people I've ever met. And this conference, behind the scenes, this woman has worked so hard for all of us in so many ways. And I truly bow to you, my sister, and thank you so much for all you've done to make this possible.
Thank you to all the team. We have a lot of volunteers behind the scenes from all the region. I approach this moment to say that Ninoska, for example, from Bolivia, has been working until midnight, almost 5 days of the week in the last 2 months. And also Sonia, who is working every day 2 to 3 a.m. in the morning in Portugal, and all the team of the Peruvian Medical College that has been working. Oh, sorry, that is so bad. I don't know why. I think that my mic is not working today. Anyway, so I will try to do my best. Okay, so and to all the Peruvian team, to Galia, to Patricia, and to Dr. Marta, to Roxana, to Delcy, I'm losing names now, and to Ivan, and to Amana. I don't know. It's a lot of people. It's a lot of people that has been working so hard the last 6 months, but I think that the last 2 months was a crazy journey with also with the Brazilian team of the academic consortium, and also with the streaming team and the interpreters. But that is a wonderful example of what we are able to do if we go together between the different regions, between the different institutions, that at the end, like Dr. Rogers say, and you will listen next week, because I listened before because I did the pre-recorded presentation, so I don't want to spoil it that conference. But I think that many of us have a beautiful dream about how healthcare system can be and how could be, and that is the dream. So I think that if we work together in the different levels, and how the traditional complementary integrative medicine could be and could done that integration in the healthcare system and service, for sure all the healthcare system will transform, and we have that in our hands. I think that many of the healthcare systems right now are trying to move and are trying to improve, and the World Health Organization is working hard with all the strategy of universal coverage, and also with all the move of the global goals. But I think that the TCIM community has many things to do and has many knowledge and experience to contribute with that global health coverage. So I think that we have been joining and putting together our ways and our rivers, whatever that will be the road to arrive there. And we are sharing a common dream that is like the health to everyone, the health to everyone. That's it. So thank you very much because I think that at the end, the reflections about networks is that we are working together, and working together, we do more.
Just to be in line with this by heart, we ever feel it's true that you are like a family, because the dreams and the goal is the same, to abroad all that field of care. And thank you very much, Natalia, especially to the organization. Now I would like to go on and introduce another member of the family from Australia, John Adam. Just a minute. That John Adams, it's important to mention that it's special day today. It's his birthday, and it's with us here to celebrate his birthday with us, giving us opportunity to hear from your experience. You talk about the perspective, the world perspective of research in the TCIM. And John Adams is a distinguished professor of public health and deputy head of school research at the School of Public Health University of Technology, Sydney, Australia. He's also director of the only public health research center in the world exclusively focused on TCIM. That means the Australian Research Center in Complementary Integrative Medicine, ARCIM. And John has also recently awarded a prestigious Fulbright Senior Scholarship in the last 2 years. So, welcome, John, and please feel free to present now.
Thank you, Ricardo. Thank you, everybody. I shall just share my screen with you, if I may. Wonderful. So thank you, everyone. It's been an absolute pleasure listening and reconnecting online with everyone. It's lovely to know we're a big family. I don't want to inquire about where I fit into in that family, because that might get a bit dodgy, but it's lovely to see you all. Thank you. Just to echo what other people have already said today, it's a great opportunity, and thank you very much for the honor of allowing me to share some reflections and thoughts with you all. A lot of what I want to talk about in the next bit of time is really, I suppose, to some degree, it brings in many of the themes that other speakers have already been touching on and talking about and expanding. And what I'd like to do is, first of all, just say that to make some qualification about my statements, which is I don't pretend that what I have to say is comprehensive. I don't think it's the necessarily going to be the only focus or main focus for many people, but they're just some ideas I've had over the last 25 or so years following this field, being part of the TCIM field and family. And obviously we have a lot to be excited about in terms of where we are right now. But I also would like to, in this talk a little bit about some ideas that I have that we can share and talk about where we need to go next, and what types of things can we do to remain vibrant and to remain exciting as a field, not just for ourselves, but for others beyond. So just very quickly to contextualize my position and what I do. Thank you, Ricardo, for your very generous introduction. I am a distinguished professor of public health. I want to keep going back to that field of public health from time to time throughout this talk. And as was mentioned, I'm the director of ARCIM here in Sydney. I'm also a co-convener of the Public Health Association of Australia's Special Interest Group on Complementary Medicine. And another couple of things just to mention, because they tie in with what I'd like to talk today about. One is that I've had a senior fellowship at Oxford University for well over 10 years now. It's ongoing as part of a leadership program in primary healthcare. And also I was just recently, as Ricardo mentioned, but it ties in quite nicely with some of the themes of today's presentation. I received a Fulbright Senior Scholarship and spent some time in Boston, in Massachusetts, just before the lockdown kicked with COVID-19. So I managed to get home with my family after 3 months in Boston, thank goodness. So just quickly to continue with that, ARCIM, for those of you who are listening or listening to this and don't know what our center does, as was mentioned by Ricardo, we are the only public health or global health research center and group which is exclusively focused on traditional, complementary and integrative medicine and healthcare. We've been extremely productive over just a short period of time. 2012, we first got together formally, even though some of us were working together behind the scenes for some time previous to that. We have over recent years, we've published over 900 research manuscripts on TCIM. We've attracted a fair, decent amount of competitive external funds from government in Australia, but we've also had funding from overseas, including consultancies with the World Health Organization. We've had money from the Canadian Institute for Health Research as well. And we've been doing a lot of work partnering with ministries of health around the world, different places, including in the Americas. We've been involved in consortiums and collaborations with different ministries of health. We've also, as I mentioned, done work with the World Health Organization, and we do a lot of domestic partnering with external health, but also beyond health stakeholders, which I'll talk a little about. And finally, I think the other thing to mention about our center, which again ties into some of the themes I want to explore in more detail later, is that we've been initiating some international leadership programs for early career researchers in TCIM. We've been doing that now for about 6 or 7 years, and we currently have 4 programs. There's one that we share with some other institutions, which is exclusive to chiropractic. We have another in osteopathy. We have one specific to naturopathy, and we have another which is labeled a CM leadership program, which takes in a whole range of different fellows from around the world in different modalities with different interests. I'll come back to some of those issues in a moment. But what I'd like, the meat of what I want to talk about today is I realize that in pondering the question of where do we go and what does the future look like, there are some other very fundamental questions that I think it would be worthwhile for us as a field and a community of scholars and practitioners and others around this topic to be thinking about. And that's primarily, why are we doing this research in the first place? Why is TCIM research worth doing? How do we do it? What type of things do we follow? Again, there are ingredients from what other people have said, and many people have touched on things like rigor and scientific evidence and what have you, but I'll talk a little about that. I think another question that's really important, and it's extremely exciting to see the broad spectrum of interest, not just geographically with this summit, but also in terms of backgrounds, disciplines, the kind of expertise that is coming to tackle major challenges, questions, and opportunities around TCIM. And I think that's another question to ask, is who should do TCIM research? Who should be involved in it? And I've got a very broad idea myself, a very broad perspective of who should be involved. What does it currently look like? Well, TCIM research, as we know, there's been a massive growth, and I don't want to spend too much time just trying to list all the research areas that are currently being investigated around the world. But I will talk a little bit about where are we actually up to in the scheme of things. And I think, again, many of the reflections of the great presentations I've been listening to today and the speakers who've come before me have touched on some excellent initiatives and developments that are happening in their part of the world and internationally as well. And then I want to get to this idea of building up with all these questions. What does the future look like? Well, again, as I mentioned, to qualify, I'm going to pick out some things of particular interest to myself and our center, but I think that there are themes running through the whole range of activities that people probably need to be undertaking over the next period to make sure, as this last question shows, we can not only keep growing, but we can ensure that our research is sustainable and that it continues to provide lots and lots of good insights for communities, for health systems, and of course, for everyone on the planet. So why do TCIM research? And I think it's always lovely as an individual as well as a collective to occasionally check in and ponder what the mission is that we're all involved in. We can often day to day, particularly in a world like the environment we're finding right now, it's often a scramble of survival. But what we really need to be doing is finding some space so we can have a deeper thought. And of course, I started where most of us would start, which is with simply a curiosity or a reflection upon what are the questions that we want to ask, not just of TCIM, but of our healthcare systems, concept of health itself, and of course, the global environment in which we all find ourselves in connecting our health with other people's health and their well-being. So I think the curiosity, the academic curiosity, is obviously a good starting point. But we, as I've been listening in the previous presentations, we do need to be mindful that we have surely a wider mission, and that is not just to appease ourselves and to explore our own personal interests, but to realize that we have a place in the world in the research sector. We have a place in the world in helping global health issues and challenges, and also that there are so many other stakeholders involved. And if I could say, many of them with much more of an interest in what's going on in the research scene than maybe even what researchers have. I'll come to that in a minute. I think the other reason we do TCIM research is, of course, we need to influence and we need to convince other people, including ourselves, that the kind of progress we're making in terms of empirical evidence is a good one and it is worthwhile. So obviously there are schemas and there are scientific templates that to some degree we all need to follow about collecting the correct evidence. Are we going about the data collection and the kind of interpretations we're making about all sorts of practices, behaviors, and uses in the right way? I think another part of this is obviously, and this is going to be a major theme of my talk today, is the idea of translation and impact. Our mission is it has to be relevant and connected to the real world. It has to be about the consumers of health, the users of healthcare systems. It has to be about all the stakeholders that have vested interest in what's happening in their communities and also on a global level. And I think the main ultimate thing about why we do TCM research surely is this cannot just be an academic, theoretical or conceptual process. It also has to have real change at the end of it. It has to have a practical praxis or a mandate, if you like. And I think that's something we should just keep in mind from here on in, is that everything we do, both at the summit, internationally, and in our own backyards in different jurisdictions, our ultimate goal is, I am sure, shared, which is we want to deliver improvements for individuals, for communities, and for whole healthcare systems. So very, very quickly, no need to really go through all the intimate details of how we go about TCIM research, but I do find it, as someone, a senior person in Australia in this field, extremely encouraging at the professionalism, at the scientific quality of what's now being produced around TCIM and all the issues that are involved in it. I think we've come such a long way just in the 25 years that I've been involved in this field, somewhat from a cottage industry of slight interest of individuals to now, and as we will see later in my talk and as other people have presented, we've now got whole infrastructures and networks. And if I may say, what they are doing, those infrastructures and networks, they are facilitating and promoting somewhat professional, quality, valid, and critical ways of thinking and approaching data collection around TCIM. And I think there's a number of other things about how to do TCIM research that we really cannot lose sight of. And that is the fact that we have to think about this as a broad endeavor. Yes, we have clinical perspective and clinical design. Yes, we can have pharmaceutical and pharmacological design and research. Yes, we can have basic science. We can have public health. We can have global health, health services research, health economics. The list goes on and on. But if we are a broad community with an open mind, then we can actually get a long way by using mixed methodology. We can be extremely nimble, versatile, and flexible about how we ask questions and how we answer them, again, for our benefit and for others. And I think it's also important, particularly in the context of the traditional, the indigenous knowledge that is involved in the TCIM sector, that we remain respectful of both the scientific modern template of what good, valid, reliable data collection analysis needs to look like, but also at the same time being respectful of the relevant traditions and cultures, often of where these medicines have not only originated, but where they are also being used, refined, and we can really discover much of the information ingredients that we need to know to interpret and understand them. And I think on that particular note, I think to extend the idea of being respectful to cultures and subgroups and traditions and ways of knowing is that we also need to think a little bit about how we partner with real people in the real world and their communities. And I'm a big advocate for co-design. A lot of the work that we're doing now at Arkham with lots of partners around the world is really starting at the grassroots level and not just treating the people that we are interested in terms of their health and their healthcare and their healthcare use, but treating them not as subjects, but as partners and co-designers of that research. And this is where, if you like, a social science sensibility and a qualitative perspective becomes extremely important. And just to look at the yellow little message there in the black box on the screen is the fact that I think all these features are really essential for convincing and persuading and bringing with us not just our internal family and making sure we're coherent and that our message is on message, but also that we can really attract external engagement and we can be influencers of the wider scene. So who should conduct TCIM research? Well, I've touched on this in a number of ways already, but I'm really here wanting to stress that we have academic researchers and methodologists from within the academy. And again, I want to be as broad as possible as that. TCIM, if we are going to see it as a community or a family, it needs to really house as much expertise and as much insight that we can gain from across academic disciplines and fields as possible. We shouldn't be restricting ourselves, for example, to just clinical designs of randomized controlled trials. Neither should we be simply limiting ourselves to saying that everything has to be of a qualitative bent and we need to simply just explore meanings, understandings, and people's behaviors from their perspectives. What we need to be doing is bringing in psychology, bringing in health economics, thinking about the clinical perspectives that we get from within the academy, but also thinking philosophically, sociologically, historically about this topic with which we all are very much committed and we want to see lots of progress for everybody. I think another major set of stakeholders beyond clinicians and beyond academics are obviously other people in the healthcare system with vested interests, managers, policymakers, government. I mean, we've heard a lot with the network progress updates that we've heard today about all the exciting work of bringing together stakeholders and people with vested interests. And I think that work is absolutely essential and should continue. I think another stakeholder group, which funnily enough, in all healthcare research can often get lost or missed or just forgotten about, is the consumers themselves. The fact that communities are really a major stakeholder and are, as we said before, really much the focus of all the output and all the change that we're looking for. And I think it's important that we remember they should be conducting the TCIM research with other stakeholders wherever possible. Another point of difference, I think, or if you like, separation, which we need to ensure, and it is happening, I've heard it in previous presentations, is to advance our field, is to make sure that we are drawing on people with lots of other backgrounds in terms of medicine. So having conventionally trained doctors, MDs, and other health professionals is absolutely vital, along with the TCIM practitioner crowd that we also have in many jurisdictions that may formally work with or maybe outside the healthcare system at this moment in time. But we need to draw on the wider pool. We need to be thinking about anybody who can help our TCIM agenda and who is willing to do that in a respectful and a positive manner, and that we should all be reaching out and working with them as much as possible. So what does TCIM research currently look like? Well, like I say, apart from saying that we've had some exponential growth, I don't want to get into too much detail about lots of different areas. I'll leave that to the future comments that I've got. But what we are seeing is we are now starting to get, in some jurisdictions, we've got somewhat advanced evidence for lots of different areas of the academy about whether it be about health services research, whether it be about clinical efficacy of particular therapies and products, whether it be about the communication and interaction between different people who are providing traditional, complementary, and integrated medicine in different healthcare systems. But what's important is to remember, like every field, we really need to be thinking about how we're constantly maturing as a field. What's the next step that we need to take? And I would argue, and I'm sure many of you would too, we've come a long way in the last 2 or 3 decades, but we've still got a long way to go. And there are many gaps that are not only seen as challenges, but also opportunities that we should be excited about as a community. So this leads to, if you like, the main stock of what I want to talk about, which is with some focus that I've picked out from not just personal interests, but from things that I can see are going to not only are important now, but are going to probably grow in importance over future years. And I've been delighted and really encouraged to see all the presentations I've listened to previous to this talk. They've all been touching upon one or more of these particular areas that I'm keen to stress and highlight. So first of all is the fact that it seems obvious to me, if we think globally, but also if we think about all the different jurisdictions, continents, and countries of the world, that we do have to be aware that we still have much work to do in ensuring that the areas of healthcare that we're interested in, TCIM, that they're accessible and that they can be utilized for the good of all. And of course, our healthcare systems, our societies more generally, are still characterized by inequities, inequalities. We only have to look at the public health landscape to know that about resources and accessibility. But I think one area that we've started, many of us, collectively and individually in our different countries, to start working on this particular topic of vulnerable communities, the marginalized, thinking about folk in our communities who are, through no fault of their own, disadvantaged in being able to access some of the wonderful products and practices and ways to health, which our sector promotes. So I think the notion of social justice, it already is, it's been at the core of what all of us have been trying to do for some time. But I think we really need to keep that very central to our thinking from here on in. Another area that I think is going to reap a lot of benefits for TCIM, and it's already started in many jurisdictions. And I know Ricardo today in his talk has mentioned in Brazil the practice-based research network work that I'm also involved in with many others. And that's a pleasure to see that starting to advance. But I'd like to talk a little bit now about what would be the point of practice-based research? How could we all develop it and map it around the world? And what does it provide TCIM as a field, as a research field, that really will propel us to thinking about the next stage, the future, and how we can keep helping people and providing information, which, as you're going to see in a minute, is another strand of my future ideas, making what we do relevant to the people it needs to be relevant to. So quickly, a practice-based research or practice-based research network, the beauty of such an approach is, and I'll explain it in a second, is the fact that it not only provides us with a platform of evidence, but it also encourages research capacity building. So a practice-based research network, we start thinking about collecting data around healthcare modalities and their practice in the real world. And we turn the traditional research map on its head. Rather than think about experimental designs and how we can subject a whole natural setting to an experimental design by keeping lots of things constant apart from one element, we're much more interested in saying, let's start collecting data that is real, that does occur naturally in actual communities and in practices, in consultations. And how can we, from that grassroots up, then design research questions, again, in partnership with all the people involved, the consumers and the providers in this case. How can we ask research questions and answer them in language, in concepts, and in approach, which makes sense to the actual people undertaking those practices and receiving them? And I think that's not a revolution. That's been going on for decades in dentistry, in medicine, in conventional medicine with practice-based research, particularly in general practice and family medicine around the world. But it is an idea which is started to be incubated in the TCIM research community, and I think has a lot of prospects for us. And again, the reason is it is inclusive. So what we start to do is we not only grow evidence, we not only create infrastructure based on the database and the networks that we're putting together, but we're also encouraging others in the community, other stakeholders who may be of power and in places of political influence, to see that this is putting our house in order, if you like, and continuing to do so. We've made great advances in that side of things, but we need to keep moving forward in our professionalism and in how we the optics of how we externally engage and promote and influence others. I think another area which is probably, again, this is something which in our center we've been focused on, a number of us, and we've started to publish on. We're doing empirical work around this topic. And this is another illustration of how we need to draw in, and we probably need to gain influence and think a little bit about our interactions with other fields, other established parts of the academy. And as you all know, implementation, science, knowledge translation, it's not just a buzzword anymore. It's a whole field of science to itself, which has been developing for a number of decades, particularly out of the US, but equally the UK, a lot of Europe, and everywhere else around the world, including Australia. And I think this is just a perfect example of how we can interact with a field that's growing elsewhere. It's got its own area of expertise. It's got its own group of methodologists who can join people in TCIM, in our TCIM community, to work out how we might appropriate and apply such a thing as implementation science to understanding how we can improve and streamline the types of information and evidence we're gathering in terms of putting it into practice, making sure it can be impactful for the communities that we're interested in and looking to serve. So in terms of implementation science, I think in many ways, it isn't going to be the end of the scientific journey, but it is really taking a holistic, broader view of what our role is as researchers, as clinicians, as stakeholders involved in TCIM research, that we are more than simply collectors of data and interpreters of data. We have to be advocates. And this is really where I want to come through to in a short while in terms of the end of my talk, thinking about who are the main players that we need to constantly keep in mind. And I want to move to that now. I think the other thing which links in with what people have said a lot today already, and it's been really encouraging to hear, is these three words that I've put up: reflection, reimagining, and innovation. I think the future, I realize I'm talking in very broad terms here and not specifying a particular mandate or area of empirical research, but I think there's some broader behaviors, broader perspectives that we as a community need to embody and continue to embody. And that is that we can never do too much self-reflection. We can never really fail if we take time from time to time to think about where we're up to, what's next, how do we all work together to keep this progression and this journey going. I think reimagining, that's part of the fact that what came before, the data we collected before, the types of approaches and areas of interest we had before, they will remain valid, but they may not be quite so essential or vital as other areas. We can always draw in different ways of doing the science and the practices that we're all involved in TCIM research. And linked to that, of course, is innovation. We should be not just reimagining, we should be reinventing ourselves at certain times in this journey, because we don't want to remain stale. We need to remain competent and we need to remain appropriate to what's happening in the real world. And COVID is a classic example of that. And again, it's been extremely encouraging to see the engagement with this recent and current pandemic from within the TCIM community, just in thought leadership, just in the type of empirical manuscripts that I'm seeing that are coming out, and also the contribution we're trying to make to the bigger public and global health challenges that we're facing. So I think a bigger issue is not just simply about where do we go from here, but of course, I'm going to end today by just giving some reflections and thoughts about how do we end up ensuring that where we go and how we get there is sustainable and keeps growing. We've got to have a future for TCIM research. Again, I think it's very encouraging just at this summit to see the types of fantastic innovations and initiatives that people are developing in different parts of the world and internationally. But I think it's really important that we do keep an eye, all of us, not just on research, but research growth, research capacity building. And just to give you one example, going back to the leadership programs that we currently run at Arkham, that really is our contribution to try and show some international leadership with a group of what are now senior TCIM researchers in our group. How could we sat down 6-7 years ago and thought about what kind of contribution can we make to making sure that the field that we're in and that we're all very excited about and passionate about, that it's sustainable and that it can continue to grow rather than perhaps have peaks and troughs constantly based on political whim. And one of the things we came up was to actually use our skills in leadership and mentorship to nurture and grow our own ranks of TCIM. And when I say our own ranks, I'm thinking about our global family, not just here in Australia. So we now have over 60 TCIM research fellows who are on the 4 programs. They're all doing fantastically. We're helping mentor them through their careers individually, but we're also encouraging them to collaborate with each other. And I think the elephant in the room always with every area of research is, of course, the internal and external politics that's involved. And one of the things that we're trying to do with those leadership programs, which I know other people are doing in their initiatives, is to break down some of the political divisions that can happen between all the different stakeholders that we all need in the camp for this to develop and to grow properly. I think the other point to make is just about the collaboration and partnership. There's again great work going on with all the networks and all the consortiums and collaborations around the world. And we have to keep that going. That is now the hallmark of good academic research and into the future, and it has been for some time, is collaboration, collaboration, collaboration. And I think we're on the right track there, but we need to check in occasionally and work out, do we have the right partners from across the academy, or do we need others? Are there other disciplines and perspectives that as they develop, we can bring in? And a good example would be not only implementation science, but complexity theory, for example. Developments that might be happening in neurology, that might be happening in other parts of medicine, clinical perspectives, and healthcare professions. And I think the other future guarantee, if you like, or attempt at guarantee, is to keep engaging with external stakeholders. And here I'm thinking not just about the power brokers of government and policymakers, but also we have, and this comes to the very last point on this slide, we have a lot of goodwill with the community themselves, with not just individual patients, but with whole groups and sectors in our cultures and societies. And also, I think we need to make sure that we are tapping into that goodwill. And we're not only serving those people, but we're being very transparent about how we want them to be part of this journey. And that's not an easy thing to do. There's a lot of rhetoric about being open and inclusive, and how might we do that? But we need to think long and hard as a research field, I think, and continue to, about how we can bring into the fold and we can partner truly and co-design with all the different stakeholders in community and patient groups. So I think finally, just as if you like, a personal reflection again, not only has the summit reiterated this to me and re-emphasized it, but it's been around for some time now. We are a maturing research field. We do have growing ranks, but we also need to keep striving to make sure that we are sustainable and that we can capacity build and that we are providing transitions and futures and careers and journeys for people who are at the beginning of being interested in TCIM research, those people who are aspiring to be mid-career and then senior researchers. And part of this, just as a final comment, is we must always be advocating internally in our organizations, but also in our institutions where we find ourselves. And a good example is Arkham, in a school of public health, in probably one of the leading schools of public health in Australia now. It's very vibrant. We have a growing population of PhD and MPH students. Arkham, I think, at the moment has over 30 PhD students just looking at TCIM within the school. But what's important is we're embedded in a school of public health. We are drawing on the broad methodological and disciplinary perspectives that we find in our everyday interactions with other people outside the Arkham Center, but also sitting around us and collaborating and working with us in public health. And I think such a model really does provide sustainability, because it provides security that our center in this case is embedded within a wider structure of thinking about health research, thinking about advancing science, but also connecting to community, to social justice, to vulnerable, marginalized groups, and remaining, I suppose, not only reflective, but remaining appropriate and respectful of the cultures, the traditions where a lot of this work comes from. I'll finish there. Thank you to everyone for the opportunity to talk today. And it's been a delight and a pleasure to listen to everyone as well. And I really do crave the time when we can all get together at an in-person conference and really start having much more intimate talks around what it is that we present as well. But fantastic to everyone. Big thumbs up for all the great work that's going on. May it continue. Thank you.
Thank you very much, John. And I believe that your repeated words, it fits very well to conclude all day that you mentioned. Collaboration, collaboration, collaboration. I think this is the word to conclude the day. And it's remarkable how the research that you are done in your group in the practice-based research network. And we're just in the pilot moment, but certainly we need your help and John Wadley to foster this. You keep contact. I received just one question before we conclude from Cecilia. It's a question to me about the studies in the one specific medicinal plant, acai, that it's. And instead of answer, I'd like to be more didactic. I'd like to share just one thing. You need to know how to search. In our website, we have the search process that connect with the Virtual Health Library of TCIM. If you put the name in Latin, not in Portuguese, and put search, then you'll be directed to the Virtual Health Library TCIM, and then you can find 388 articles, papers about that specific plant. I think this is the way we need to create tools to facilitate the research. I prefer to respond like that. I would like to allow everybody to do with me in a collaborative way the conclusion of the day, because it was asked to me to do some intelligent words, but I believe that we together are more intelligent than alone. Then if you could give some message to everybody, the conclusion of the research day, because today it's the research day and tomorrow will be devoted only to traditional medicine in Americas. Please share your thoughts to the audience, please.
If I could, Ricardo, just ask a quick question of everyone, which I think is good for us to think. The whole aim of this summit, of course, which is perfect and is working beautifully, is to bring us together from our different jurisdictions with. I noticed, though, that I'm just wondering what formal way we can move forward with that consolidation of the networks. Many people have spoken about it, including yourself, Ricardo, about how do we go to the World Health Organization or other large institutions and work out what the patterning might be of the network and all the activities that are happening in North America, in the Americas, in Australia, in Asia, in Europe, all over the world, There's some fantastic initiatives, and no doubt people have blueprints and templates in their mind of how this might work. But I wonder if we could talk a little bit about that, not to come up with some specific ideas, but just, you know, are we on the right tracks in doing that? I think we would be, but we need to also remain grounded in what is going on locally and regionally. But as long as we can remain mindful of that, then I think having such a, if you like, even a world network of different jurisdiction networks would make a lot of sense on putting us on the map. And I think it's something that we should all be supporting to some degree.
Yes, I can share quickly the strategy that we started to do 1 year ago. That idea you were in the moment when Zhang Ti in the Congress in Rio de Janeiro in 2018 quoted, look into a table of researchers that you are there, and several researchers around the globe are together. You remember? And Zhang Ti quoted the idea to create a federation of consortia or research institution connected with WHO. And following his idea, the three consortium that have that name, academic consortium, but are certainly not only, but we three from US, Netherlands, and Brazil started to talk. Roger from Netherlands mentioned today in the speech, in the video, and the idea is to identify from the 6 regions in the world what would be the institution that need to be together. It's the idea. It's not that one institution lead this, but as a group. Then you need to do a survey, look into the regions, and certainly your institution, Tabata, and here we are example of institution that need to be connected. And we thought that WHO would be the center, could be the center, even though we're not collaborative centers, depend of each institutions, but that network, like network of collaborative centers, would be perhaps one idea. We're thinking that direction. Tabata would like to talk.
Sure. I mean, we've also been thinking about this and talking about this for a couple of years now within the Academy, of really how do you create a global network for impact and towards true, like we know that there are areas that we continue to have challenges in many places. And if we could strategically come together and really identify, you know, where some of those areas where if we work together more closely, we could actually become more successful. I mean, I think that's part of the maturation process, John, that you mentioned, and that we're now finally at a place within that maturation to really start to bring together the right leaders to create that strength, you know, that strength in collaboration in a different way, right? Than we've already been doing. I mean, that's one of the most exciting things I think about this. Just the last 2 days, we have 4 or 5 more days to go, is just really seeing how we globally have been forming over the last, 30, 40 years. And really the last 10, 15, there's been such tremendous growth and maturation. And so now it really is going to require us to think about and collectively come together. And this is one of the things that we're really building within our conference is bringing us through a series of talks together as a community, almost like a global SWOT, to say, where are those areas? Where are those areas that we really need to put some more energy into? And that where we have very where we've reached a level strategically in research, in clinical education, and whatever those areas are, that we could actually join together and move the ball forward. So I'm really excited. I just feel like this is really the time to do this work. And interestingly, one of the things I think that COVID did for the global community is it really forced us into as we could only meet online, right? That it expanded us beyond anything we could have really imagined, because, prior to that, it's like there was just always so much local work being done, which is obviously important. But I think that's been one of the pearls of these challenges, is going, wow, we can really have strong global networks in ways that we had never imagined before.
Yes. One aspect that I think it's also critical, it's the fundraising to research, how to increase the access to researchers, especially in the low middle income countries, to publish and to do research, and even the language word that need to be fostered, it's English to connect us. Several groups in South America don't speak English and can't follow. But it's necessary that we increase the infrastructure of research and the collaboration. Really, we need a group that think in, like you mentioned, John, the key point is public health also, because you can't more think isolated in a private way. And as Tabata mentioned also, the COVID brings us the concept of planetary health, that before that was more idealistic, and now you are in a critical moment. I saw a movie in the Netflix 2 weeks ago from a British biologist that looking the 8 critical points of equilibrium of the planet. If you look seriously, we are in a tremendous crisis beyond we could imagine. Then this is so important to understand what means health really, that we need to be together now.
And I think, Ricardo, just picking up on that one of the great developments in our community and field, if I may say, is that there has been a real embrace of a broader way of thinking about not just TCIM, but where it fits in. So it is no coincidence that I am a distinguished professor of public health. That hasn't come about just because I chose a title. That's come about because we need a global and public health perspective, if I may say, that can encapsulate every clinical perspective and experience and insight, that can capture not only regional and local issues, but also link them to the global, international setup that we live in, and how things like food production, planetary ecological disasters, the biodiversity or lack of in certain areas of the world, all this is, as you quite rightly say, is now first and foremost in many people's thinking. But we need to be part of that solution and part of embracing that challenge, as well as still working away regionally, locally, thinking, as Tabitha said, about what's going on in the backyard, because that's equally a connection that we mustn't lose. So we got a bit of a balancing act to do, as far as I can see, but we can do it because we've developed into a mature field, which the fact we are having this conversation illustrates we are a mature field. We are no longer just talking about how do you do qualitative research, what happens when you want to ask a question. We're beyond those types of details. We're now thinking much bigger picture about our place in things. And I think that's encouraging in and of itself. But of course, we need to follow through. The talk and the rhetoric of how we might come together to have influence is something that we need to really work on.
I think one of the things, the main theme of our conference for years now has been people, planet, purpose. And that planetary aspect of, really connecting us back to the earth and what is happening, and, climate health and planetary health is absolutely integral to what we do as traditional, complementary, and integrative clinicians. And one of the things that I loved about your presentation, John, was also calling out those external stakeholders. I mean, just like we in the US, we were all siloed in I'm a naturopathic doctor. The naturopaths did their thing and the chiros did their thing and the holistic MDs did their thing. And that now has been shifting, right? That was really kind of the formation of AIHM, was bringing everyone together. And now what we've been doing over the last couple of years is also partnering with external stakeholders. We're part of one of the largest medical consortiums for climate health in the United States that are we're the only integrative health representatives on that consortium, really working around climate health. And so that's the other thing I think globally we really need to come together and talk about, is what spaces outside of our own bubble do we need to be in that we're not right now? And then who would be the best? We have so many brilliant organizations. Who would be the best representative to put forward a voice at that table or that table or that table? And that to me is where, if we have to coordinate that, right? We have to really think about and identify where those gaps are, because we now have the, we have the force to be able to step into those places. And that's what, again, I think is just where we're at. It's the opportunity now that we have.
I'd like to mention one experience to honor the Peruvian region. I think 2 or 3 years ago, I come to the International Congress about organic foods. And I realized how Peru has the richest biodiversity of food in the world. And they mentioned why they could avoid the entrance of the pesticides and the transgenics in a very good way. And was from external stakeholder, was from the gastronomic power. It's not from the health professional, but come from the gastronomy, the food quality. Then it's an example of partnership, intelligent partnership that need to be done. And it's very impressive. If you could come personally to Peru, the food, it's perfect. It's wonderful. And accessible, the diversity.
It's a great example, Ricardo. It's a great example of the restaurant and chef industry globally is huge, right? And those types of partnerships, across other industries that are also aligned with what we do, that's really where we need to go.
Yes. I would like to conclude saying, let's have a very good meeting in a very good dinner restaurant around the roads with organic foods. And thank you very much. I hope to see you tomorrow.
Thank you all. Good evening. Good morning.
Go ahead.
I just I plus to all the reflections. I think that you did all the important reflections today. But just to take in count some of the comments of the audience, of the public that are in the YouTube channel, and about all the complexity that has the definition of the integrative medicine, how we include there this mix now, that this meet between the different traditional complementary medical system and also therapies. And so that is a reflection to do. But about research, a final idea for the Latin American countries and for all that countries that are in a low media, that are countries with low and media incomes, is that we need to improve the education, because we are thinking about how improve research, but we need give that in the education. We know all the academic programs in our universities or in our bachelor's degrees programs are focused in the research. They are just focused in the clinical skills, no, and in the theoretical background of each TCIN. But most of the academic programs don't have a view from the point of view of the public health, and most of them also don't have a view of the importance of the research to the public health. Usually, the academic programs in the universities and institutions took the idea of the clinical knowledge and the clinical outcomes in the research, but it's like that the bridge between that and the public health is like something that just is something that is not there in the academic program. So I think that that is also one important reflection, and I think that all our universities or institutions, because we know that not all the TCIM are in this kind of academic institutions, but for sure, if we include a reflection and a view from the point of view of the public health, I think that also we will have more conscience about what we expect with the research, what we are expecting with the outcomes. Is not just the effectivity, is how I will improve the health of the communities. So I think that we need something more with that, and also we definitely need teach and need learn for all the other countries. I think that in Latin America particularly, and for sure in other regions, our students don't have enough knowledge in research and don't have enough skill, and it's really stressing for them when they have to do a thesis in the universities, and it's because they are scared, no, that they think that do a research is like something so scary. So I think that we can encourage our students, but also all the colleagues that has been working in the field many years, but they have uh, they have never published anything because they are just scared. They think that they are not able to do it. So I think that there are also things that we have to think and to take in account with that.
Thank you.
Like just to mention, who is asking about training have to wait 6 days. In 6 days, you have 1 day devoted only to training, and then the insight need to be kept. And we go on. We're just in the second day of the Congress. We have more 4 days. Then
Paciencia.
yeah, paciencia.
A general information for tomorrow, we will be starting the third day of the summit that will be focused on traditional medicines in the Americas region. We will starting at 8 a.m. of Peru, Ecuador, Mexico, Colombia, 9 a.m. Chile, Bolivia, Cuba, Washington, D.C., and 10 a.m. Brazil, Argentina, 2 p.m. in Spain, and 3 p.m. in Berlin. Thank you very much.
Adiós. Gracias.
Gracias.
Thank you. Goodbye. Goodbye.
Bye.